Assalamualaikum warahmatullahi wabarakatuh, and good morning, the honorable, our speakers, and also our chairperson for today's session. All of the participants, I would like to warmly welcome you again on our third day of the fourth ICO-BTD, the International Conference on Biophysical Technology in Dentistry. And today is our last day, and we are going to enter the seventh session of our conference. And we're going to have two presenters for today. For this session, Professor Keng-Liang Ph.D. from Taiwan, and Dr. Gigi Muhammad Gazali Mars, specialist bedah mulut consultant from Indonesia. And as our chairperson for today will be Professor Susilowati Mujari, and I'm going to give a brief introductions about our chairperson. Born in Batang, April 1955, graduated as a dentist from Gajah Mada University, Yogyakarta, and magister graduated from also Gajah Mada University, Yogyakarta, and PhD awarded from Hasanuddin University. She is now one of our lecturer in the orthodontic department of dentistry faculty Hasanuddin University. To Professor Dr. Gigi Susilowati SO, please, the time is yours.
现在看不到他们的影像，只看得到图片。对啊，刚才。
Good morning, ladies and gentlemen. First of all, let me thank the Almighty Allah Subhanahu wa Taala. Because of His blessing, we are able to join in this virtual conference, namely the fourth International Conference on Biophysical Technology in Dentistry, or ICO-BTD. Secondly, I would like to extend my gratitude to the Dean of Dental Faculty of Hasanuddin University, who made the virtual conference happen. And also to the committee for giving me the opportunity for guiding this presentation. Ladies and gentlemen, we have two speakers in this session 7. These are Professor Keng-Liang from Taiwan and Dr. Muhammad Gazali Mars, Sp.BM from Makassar. Before we start the presentation, let me read the curriculum vitae of the Professor Keng-Liang Ph.D. Education and experiences. Obtained his Ph.D. degree from Graduate Institute of Mechanical Engineering, National Chiao Tung University, Taiwan. He joined Taipei Medical University to pursue the cutting-edge research of biomaterials. He was a Dean of College of Oral Medicine at Taipei Medical University, also Director of Research Center of Biomedical Implants and Microsurgery Devices, the Director of Research Center of Biomedical Devices on Prototyping Production, and Distinguished University Professor. Professor O devotes himself to novel research in the fields of biomaterials, bioengineering, biosensing, bioimaging, and translational medicine. In addition, he establishes extensive collaboration with industry and has played a leading role in developing medical devices for health professionals worldwide. He is the leader and organizer for biomedical products design, production, manufacturing, testing, legalization, and market planning, with support from teams of scientists and researchers with expertise in different fields. With the outstanding accomplishments in research and invention, Professor Wu receives the award of the 10 Outstanding Young Persons of Taiwan in the year of 1911. Today, he is CEO of 3D Global Biotech Inc., which is a spin-off company from Taipei Medical University. Current position, Chairman of 3D Global Biotech Inc., spin-off company from Taipei Medical University, Taiwan. Chairman of Union of Academic Biotech Ministry of Science and Technology. Chairman of Taiwan Society of Blood Biomaterials. Chairman of Taiwan Yangi Anti-Cancer Foundation. Professor at Department of Dentistry, Taipei Medical University Hospital, Taiwan. Chair Professor of Management and Health Institute. Visiting Professor, Health Sciences University of Hokkaido, Japan. Visiting Professor, Faculty of Dentistry, Universitas Gadjah Mada, Indonesia. Visiting Professor, Faculty of Dentistry, Unhas Makassar. Professor, Department of Dentistry, Taipei Medical University Hospital, Taiwan. Professor, Department of Dentistry, Cathay General Hospital, Taiwan. Professor, Department of Dentistry, Taipei Medical University, Chung Ho Hospital, Taiwan. Council member of Taipei Red Cross. President of Institute of Plasma Engineering, Taiwan. And consultant of Taiwan Association of Dental E-Learning. Consultant Taiwan Academy of Dentistry. Consultant of Taiwan Association of Oral Healthcare Management, Consultant Ministry of Health and Welfare, Executive Yuan, Taiwan. Ladies and gentlemen, now we are entering to the presentation session conducted by Professor Keng-Liang, Ph.D. Professor Wu, the floor is yours now, please.
Okay. Just use it. Okay. Hi, everyone. Can see my slide?
Yes.
Yes, Prof,
Yes.
you can see clearly.
It's clear. It's okay.
Yes.
Okay. Okay. So thank you. I can join the international conference on biophysical technology in dentistry. I many times to join this conference, so I'm very happy the conference I can join it. About today's my topic is biophysics. Is biofabrication of the bone tissues approach challenge translation for bone regenerations. Today is about my content will including the market, innovations, academic review, RD simulation, cell model, animal model, and the clinical trials. These content just very few fit for the product to do the translations, also including the clinical trials. Finally, you can apply it in the market. So about the market, just you know for the dental implant, the oral surgeon, the dental implant and the prosthetic global is very huge. In our market is orthopedic, including the human and the animal market. It's also very huge and grows very fast. About the innovations, just the calcium based the bone cement is very popular application in bone reconstructions. Also including the calcium sulfate, calcium calcium phosphate. The calcium phosphate like the beta TCP and the calcium sulfate and is also very popular, but the two base of the bone graft is very different the property. So now that some product like the calcium phosphate just applied in the long-term resorptions, bone reconstructions. But for the calcium sulfate, just applied for the short-term absorption and induce the bone formations, can apply to use a calcium sulfide. So today our innovation and introduce for everyone that is calcium sulfide by use new process like the rapid thermal process technology to produce the pure alpha calcium sulfate instead of the beta calcium sulfate. For the alpha form, that is alpha calcium sulfate hemihydride. That is a resorption for the bone defect. His property that is nanowire as a nanowire. So it can use osteoconductions and it can easy shaping and modeling, and can also as activated for the PRP and the PRF. So some our innovation that is alpha form can in containing with the growth factors that is taken from the human being's blood. The human being blood have the Sp cell, the stem bio cell. That is nanostructures. So you can combine it with the alpha form, can apply it to clinical use. Now it's also approved by FDA. Now it's a phase 2 clinical trial. So what is Sp cell? The Sp cell that is maybe you can also do it. That you can use take it from the human being, then you can use to take from the human being have the Sp cells. Then you can use the Sp cells can combine with some bone graft. The bone graft can become the class-rated product. This product can the growth factor can induce by the calcium sulfate. Now that you also can see the this movie that is the dental implant. If you have some bone the bone graft treatment, then the blood can easily surface. You also can see that it can easily soften the blood or the series from the dental implant. And like the pig, after you treatment by the alpha formol containing with the growth factor, the SB cell, you just can see after 1 week it can stand up. So this is can use in the clinical applications now. So in FDA the phase 2 the clinical trial. So based on the academic the review, there is calcium sulfide. Of course, it had a good biocompatibility, osteoconductivity. So he also a long time to apply and use in the clinical. So have some type of clinical high hemihydride can use in clinical. Here two types. One is alpha calcium sulfide hemihydride, and beta calcium sulfide hemihydride. But in clinical applications, the calcium sulfide hemihydride is more used on filling the bone material. Just because he can he have the high biocompatibility, the bone rigidity, and the biodegradations, no toxicity. The other important is can induce the bone transplantations and osteo integration with the implant applications. So the medical alpha hydrated calcium sulfide is you can use a spatial fabrication process. Can use the phase transformation. You can control the crystal structures. You can control the spatial size and the shape, because the spatial specific the size and the shape can induce different performance in clinical applications. So just you can use the different the fabrication, the process can prepare the different the calcium sulfide hemihydride can apply in the clinical trial. So just you know the property of the calcium sulfide, the hemihydride. But there is a different the long growth rate from the C axis. That is alpha hydrate, but the beta hydrate is just shortened. But these two type is very different performance. Like this one is a needle type, a long type, the calcium sulfide. This can induce the platelet, the growth factor release. But the shortened, like the beta hydride, is no the type of longer C axis, so he can't induce the growth factor release. So if the needle type, the calcium sulfide can induce the bone resorption quickly, and can induce the calcium sulfide release the growth factor, induce the bone regeneration quickly. So like this one, this is a needle type of the calcium sulfide. So this is a needle wire. So this can induce the long C axis, then can induce this needle type the calcium sulfide can activate the platelet, then release the growth factor, then can enhance the osteointegrations, the bone defect. So the many applications, the calcium sulfide combined with the PRP, they predate reached plasma and the restoration of long bone defect in the animal study. Like this one, just so you see, if your calcium sulfate with the PRP, that is a very high bone degeneration of the bone area. Is very high percentage. It's approached the 18-fold 0.6. So that is shows us if the calcium sulfide combined on the PRP, then can induce the bony ingrowth, then can induce the bony formations. So this figure just to show you if you only calcium sulfate or only the PRP that is combined is better than anyone. You also can see from the histology, the micrograph. You also can see about if the calcium sulfate including combined with the PRP can very obvious can Keng-Liang is a new for bond. New bond formation is very obvious. So today you also can see the calcium sulfate, the predator-rich plasma. The calcium sulfate also can act as activators. Like this process, the prepared the calcium sulfide with the platelet, named as you apply it in this applications in the biases that is obvious. The calcium sulfide with the platelet either have the new bond formation is very obvious, but for the controlled sample, there is no bond formations. There is even only in the calcium sulfide is just a little new bond formations. So a little bit the new bone formation only the calcium sulfate. So it's just showed as if you wanted to have the better the bone formation, you just need the calcium sulfate including the blood interactions. Then the calcium sulfide have the needle type, then can induce the growth factor release. So like this one, that is also the research of done the orthopedic the bond bioacid storage. Just you can see the you compare it with the DFDBA and the calcium sulfide with the platelet. It's obvious that there's DFDBA and if the calcium sulfide with a platelet, it's obvious that they have the calcium sulfide with the platelet, have the highly the bony formation is very obvious. So that is just you only have the DFDBA. It's just not a bit named including the platelet with the bone graft. This is showed as a concept that is platelet is have the highly including with the growth factor. Then you can activate it by the calcium sulfate. Then can release the growth factor in the surrounding and the defect. then can enhance the calcium ion absorption with the growth factor, then enhance the bone growth and the bone formations. This concept is very important and in applications in clinical. In addition, the calcium sulfide also can combine with the PRF. That is historically, if you can intrusion, you also can predate the fiber in the plaque mix with the calcium sulfate, then put into the socket. Then you can induce this socket bone formation. It's a very important application. The other is you also can augmentation the case applications. So this is also very important in applied in dental implant and the augmentation the cases the application. So today from the market innovations and the academic review, now that we just will add the simulations, that is we wanted to know about the calcium sulfide hemidihydride. If you treatment, you use the rapid thermal process treatment, you can make it become the needle type. The needle type. This needle type is very important. They can do as the predate, the growth factor, the activated. Then we can release the activator, the growth factor from the predate. So this needle type is very important. So we just tap the image just from the transmission electron microscope. That is very obvious. You can see the calcium sulfide, the needle wire. The structures is about his diameter is from the 10 nanometer to 25 nanometer. So this structure is a needle type. So this needle type can as activators. Then you can release from the growth factor. So we also detect. You needed to know his phase transformations of just from the calcium sulfide dihydride become the hemihydride. This is very important because the calcium sulfide hemihydride can mix with the PRF or the Sp cell. Then he have the needle type can activate the Sp cell, or the predate release the growth factor. So from this figure, that is a very obvious phase transformation from the calcium sulfide dihydride to the calcium sulfide hemihydride. So like this one, you also can see the calcium sulfide dihydride. You can see it will transform from the hemihydride from this peak. Very obvious. So this is a dual phase. You can found become the only single phase. That is a calcium sulfide hemihydride. So this single phase is very important. Can combine it with the PRPM, the PRF, or even and the Sp cell. And this one, that is, if we have the needle type, single phase, the calcium, the calcium sulfide dihydride, he have the highly the hydrophilic the structures. That is a very easy absorption. The blood, the PRP, PRF, and the SB-cell interactions. So this is very important. It can enhance this the growth factor, the absorptions. Then can induce the surrounding the bond regenerations. So today we also see about the cell model. This is very obvious. If you have the calcium sulfide hydride structures, after the 1 day, you can see it become like the bony like the structures will very attached with the bone cells. They also including the porous structures. The porous structure is better for the SB cell growth, bone growth into the porosity structures. So, and also the predator will release the growth factor. So it's easy to enhance the bone growth into the porous structures. And then after the 3 days, it's very obvious that it's long cover, the long area, the bone cell. This is the calcium sulfide hydride is obvious is activated, can induce the growth factor release and into the porous structures, then can enhance the bone cell the growth very quickly. The other cell model we also checked by the cell activity. That is very obvious. If the cell with the not only the bone cell, you also ADSC, the cell, the stem cell is also very obvious, can enhance his the growth factor, can enhance it very spread and differentiation or profilation very easy. For our animal study, we have to just do the Ken model, mice, rabbit, and the mini pig. So wait a moment, we will show you about the embryo or his model. We just showed for everyone that from 1 day to 12. In the 7th, you just the basal, blood vessel will beginning to close. And the 18 days will growth. So you just can do as a surgery in 18 days. So about our study, the chicken, the embryo, you just can see the 7 day and the 18 days. 7 days, you just can see his blood vessel is become beginning the growth. Then the 18 days, you will growth. Then you can do the surgery 18 days. So for our study, we will control the 18 days. So you just after 18 days, you will do the surgery. Take his fibula. His fibula, then put it into like this one. Okay, So you can do the study just at the 18 days. You can take the 2 egg, then chem culture system, then you can take the 2 egg, and you can destroy the 1 egg. Then you can do the surgery, his fibia, then you take it, then to put it into the other egg. You can see about his bone regenerations, bone reconstructions. Everyone approach it 1 week. So like this one. So you can take the do the surgery, these 18 days, the chicken embryo. Then you do the surgery, you take his fibia, then they put that into this hole inside, and you can see the angiogenesis, and you will accounting his with and without the alpha form. You just can see like this one. This province is just very obvious. It's growth surround into this fibia. Also can take either from the micro-CT, just from just to know about his bone regenerations. And I like this one. It's very obvious. There is a new bone the formation. Very obvious. For the alpha former, the new bone tissue formation is obvious. So this alpha former, the type, it is the bone defect can enhance his growth factor release, then can enhance the surrounding his bone absorption, the growth factor, then induce the bone tissue the formation quickly. And then we also do the calcium sulfate with the Sp.Perio. Then we just see about this the G former. Then this G former is very obvious. Is the bony formation is obvious. That is a defect. We make a defect in the mice. Then you just can see about his bony formation, his bone structures. Like this one, after 3 days for this alpha former, can see about his defect. This is for the FDA the approved data. Is a critical bone and critical side defect. 3 days is obvious that is can enhance the bone growth. In addition, we also do the study for the alpha former and the G former. That is the alpha former and the G former. The G former is including the Sp.0. That we just applied it in the rabbit in the sinus. Then we can see about his HU value for the 2 week. The G former is very obvious. It's better than that is a bone density is better than just only use the alpha former. That is if you combine it with the Sp.0, that is better can induce the bone regenerations. That is very obvious, including about 21%. So you can see the Sp.0 is a better just only use the alpha former application in the bone defect. We also check about the alpha former and the G former in the big animal for the for the rabbit. That is obvious. That is very different. About the G former, that is 37%. In just in short terms, that is very obvious. For this one, the yellow dust, there is a new tissue in G former area. But that is alpha former to applied in FDA approved in vivo the degradation test. That is very important for the product approved the FDA. So we also do the that is G former, that SP alpha former combined SP cell, that is G former. Sorry, this is G former. The G former is with the SP cell is applied in the socket, and also combine the SP cell with the dental implant is two animal study. So the alpha former and the G former is alpha former combine the SP cell. We do the mini pig study. For the broader waiting the two piece the dental implant, you just can see if the dental implant with the SP cell the treatment, because he have the narrow structure on the surface, is easy to absorption. The broad the absorption on the dental implant at the same time, so it's very obvious. Some dental implant that is without the broad weightability. So that you just know the broad weight ability is very important. Just because whether a broad weight ability is can enhance the platelet and the stem cells very quickly absorption on your implant body. So your implant body, implant structures have the stem cell and the growth factor attached on the surface, then can induce a calcium ion and the bone growth very quickly into the implant, the surface. Then you can induce that is a primary stability. So primary stability is just the primary stability is very important for us, our osseointegrations. Like this one, this is absorption. If the dental implant have the weight, the surface, then can enhance his structures. So like this one, even though you use your surface have the narrow structures, have the outside layer, can induce his implant surface can have the like this one, the better the weight, the broader weight ability. So that is a broader affinity, the capability. It's very obvious. So like this one, Straumann, if the surface is dry, this one is Straumann dipping in the DR water. This is a wet surface. That is very obvious. Just is a 100% broad affinity on the surface. So it's very important. This is our animal study. It's very obvious. If he's a dental implant with SP cell, the treatment is on the dental implant is absorption capability is very quickly. For this one is no treatment, so it's very obvious. And about his SP cell the treatment, his osseointegration rate is also very high, like this one. So for our clinical trial, that is, you just see, we just use the HU value to determine the in CT examinations. So we just can count about his bone type. So the bone, different the bone type have different clinical variations about the bone quality. So about his bone regeneration, we just found the HU value, the statistic. So like this one, you can use this alpha hormone combined with like this one. This is a granular alpha hormone combined with the broad PRF. You just you do it, you just take it, then put it into this granular gel. Wait a moment, you see about this kind of gel, and then like this alpha hormone can combine this broad platelet and the normal saline, so you can easy shaping and modeling. So this is better as you apply them in clinical. And then now like this, this is a granular alpha hormone and combined with together. Then now it's a mixing, and you will take it become a gel type. This gel type can put into like the socket, as a prop applied in the bone regeneration material, like this one. Yeah, this is a gel type, like this one. So maybe you can try it, the easy formation. Wow. Okay. So you can take this one, and the surface have the nanostructures on the surface. So this is very important. As you have the nanostructure, can enhance the imprint, the surrounding, the bone, ingress, touch, differentiation, propagation very quickly. So this one is alpha hormone combined with the SB, the G former, like this one. So it's that is activator of the platelet is applied in the defect applications. And like this one is also like the bone type, the gel, SB combined with the alpha hormone. It's obvious. That is the calcium sulfate just as activators for the platelet. So it's applied in like the imprint, before the implantology, you can just use apply in the peri or the bone defect reconstructions. And like this one is information. This one like this one. So you just do combine the SB it is obvious. Yeah. Is a can formation, so it can easy application in the your bone dental implant combined with the dental implant reconstruction. And today we also show the data that is bone density taken from the value from the human HU value from the CT examinations. We just take from the different months, and you just see data is the dental implant with SB cell. This is SB cell. This is very obvious. Is more than two times the bone density, the increasing. That is highly two times the dental implant with the SP cell T-formal applications. It can easy to induce a bone growth. Then you can do the implant more quickly. The other one is just we also use the check by ISQ. For ISQ, that is also obvious if you take from the dental after you do the reconstruction. It's very obvious the bone stability increasing for 1 month. For that is SP1 and 2. 1 month, 2 months. Yeah, it's very obvious. So for this is just only the titanium. Just for 1 month, the 1 and 2, this is the ISQ is a difference for the without any dental implant, without any SP cell treatment. So we also check the male female with the SP cell have the difference. It's obvious that is if you with the SP cell is very obvious. 2 months. After 2 months. 2 months. They all better named the male female. That is applications in that the bone density increasing is very obvious. Then we implement the stability, that is ISQ, the analysis. You just can see about is if we load and have the implant with the G-formal treatment that including the SP cell, that is about 2 times 1.76. The cell ratios are very, even though the his quality is not good, but in the short terms he will increase, very obvious. Okay, so it showed us that is if you have the high ISQ value, then it's just evidence that if the titanium have the SP cell, including the alpha formal, then will more easy condensification his bone structures. Then you can enhance his dental implant and can induce his osseointegration. Then this is for the simulation for the dental implant. If you with a stem cell therapy, then they can increase his structure. The stress decrease very obvious. If the implant have the lower stress, then you can decrease his as you implant into the bone, then you can decreasing the damage, the bone damage, then you can enhance quickly the bony ingrowth inside, then enhance the osseointegration. So how to do a decrease the implant surface the stress between the bone is very important. Enhance finally the osseointegrations. So if you have the SB cell, stem cell, or cell treatment on the dental implant, then it can decrease the stress, the effect on the bone defect, on the bone damage. So it's very important. So this one is SB1, SB2. I show just this for you, this one. Even though the SB2, this is very poor the bone quality, very poor. His densification, his bone density is very low. But as you apply the bones, G format on the inside on the reconstruction in the bone defect for 1 month, very quickly up in this almost the same the SB1. Even though SB1 he has the high HU value, and for 1 month it approaches the same. And comparing with the imprint without do the G-formal application, even though he has a better bone quality, and the imprint tool is a very poor the bone density, but it also will increase 1 month very quickly. Okay, so that is show us if you have the SB cell like the G-formal treatment, the bone density will increase. Then if I have the SB cell on implant surface, that they can enhance the his osseointegration, bone growth, then enhance the his bone density. In addition, if you have the SB cell on a dental implant, you can increase the stress effect. That is in orthopedic field, there is a stress shielding effect. So if the stress shielding effect decrease, then we can enhance quickly the osseointegrations. So my conclusion there is the calcium sulfide biomaterial such as the G-formal, that is alpha formal with PRP or SB cell. The process have the high biocompatibility. The alpha formal with the SB cell show the enhanced hemocompatibility and increase the absorption of the plasma protein. So the titanium imprint, the thickness and the functional layer is very important. You can incorporate into the gross porosity, the SB cell functionalization, the layer on the surface. So this one can base on the about the investigations. It's believed that titanium implant and the calcium sulfate with a broader treatment, such as PRP and the SB cell, have better compatibility, and they induce the initial stability as a osseointegration without the broad treatment. And like this one, we just show for everyone. This is a dental implant service without any treatment. This is porosity after you endorilation. This is affinitive surface. This is the surface with buffer layer, the SB cell, the buffer layer, and can have the neural structures. Then it can easy to induce is a bone growth inside. So you have a highly broad hydrophilic property can enhance his induce primary stability. It's better than other application and then other surface treatment process. The other conclusion that is important, the triformer that is used with SB cell, then can stress decrease with the healing times. That is other clinical conclusion, that is neurostructural surface treatment can enhance osseointegration, especially at the early stage of the bone tissue healing with the stem biopsy cell, SB cell treatment. That is just from HU and the ISQ the result just to show us. The other is special the SB cell the treatment area. You also decrease the stress, but also can achieve superior bone density and promote the early the osseointegrations. So the dental implant with the SB cell the treatment can help his osseointegration the behavior. So finally, thank you for everyone. So welcome to Taiwan. I know now is coronavirus effect in every country. So I also prayed that is everything is lucky and good luck for Indonesia and Hasanuddin University, every student, and lucky for everyone. Welcome to Taiwan after the end of the coronavirus. Thank you everyone. Thank you.
Thank you very much for Professor Wu, who has presented a very interesting topic. Now we come to the question and answer session. For the participants who want to ask any question, please write down at the Q&A box below.
What? Pardon?
For the first question, Professor Wu.
Yeah.
From Faisal. Thank you for your presentation.
Mm-hmm.
Question is how the characteristics of blood wettability affect the osseointegrations. And the second question, why the male have better osseointegrations than female?
Oh, you mean the how to get the male female the osseointegration from the implant with the SB treatment? You mean it? This
yes.
one? Yes.
The
so
first question, the characteristics of blood wettability affects the osseointegration.
Oh, okay. I just do the statistic from the 30%, 30%. The 1/5 is male, 1/5 is female. Okay, so we just statistic from the male-female osseointegration, that is before you do the surgery, you needed to get the CT HU value, then different the months you will check it again, so you can get his bone density, that is HU value. Then you can statistic about the data, and you can get the 1 month, 2 months, his imprint with SB cell. Then you can know what is his valuation, the HU value. Then you can just to know about his osseointegration rate is the imprint with SB cell or without the SB cell, which one is better, and which one is have the HU value is better than treatment or without treatment. Yeah. Okay.
Okay, Dr. Faisal, apakah sudah puas? Are you satisfied with the answers from Professor Wu? Okay. Who next? Want to ask any question more? Anyone who wants to ask any question?
If you have any other study program question, also can ask me. There is no problem.
Yeah,
Yeah,
no problem.
no problem.
Thank you.
Oh, thank you. Thank you.
Anyone who want to ask any question, please? No more question? Okay. If there's no any other questions, I will return the time to the committee, Dr. Yossi. Thank you very much again to Professor Wu, and the committee will give you a virtual certificate, and they want to send you via email.
Okay. Okay.
Oh, there is
Thank you.
one more question, maybe. From Hidayat Rusdin. He want to ask you, is there any difference between maxillar and mandibular osteointegration after implant? He just want to ask you if there are any difference between maxillar and mandibular osteointegrations after implant.
Okay, okay, this is a good question. That is M.Si and even though the application the mandible, the osseointegration is better than M.Si osseointegrations. That is the bone density. The mandible is higher than M.Si. So this is very important. So as you apply the SB cell, if you do the sinus lifting, you need more SB cell. That is the stem cell. You need more. So you need a high concentration SB cell, like you do the sinus lifting, the reconstructions. So you have a high dose, the SB cell combined with the calcium sulfide application, the meant for the reconstruction. So this is my comment. This is a good question. Yes.
Okay, thank you very much. Is there any question from participants? Okay, no more questions. Okay, I will return this time to the committee. Dr. Yossi.
Thank you very much, Professor. Before we continue to our next presenter, there will be a delivered of certificate of appreciation for the presenter, Professor O. Thank you very much for your kind sharing of knowledge and experience. We will send this certificate through email. Thank you very much, Professor.
Yeah, good. Wonderful. Thank you. Thank you. It's very good. Yeah, thank you.
Thank you very much. And now we're moving up to our next presenter. Please, chairperson.
Okay, we'll close.
Yeah, you may leave now if you don't want to watch the second presentation. Ladies and gentlemen, now we are entering the second presentation, will be delivered by Dr. Gazali, specialist bedah mulut. And before entering the session, I will read the CV of Dr. Gazali. Name, Muhammad Gazali, spesialis bedah mulut, Mars. Educational background, he was graduated as a dentist from Hasanuddin University, Faculty of Dentistry in 1988, and specialist bedah mulut from Faculty of Dentistry Unpad 2001, and S2 Mars Pasca Sarjana FKN Unhas in 2012, and for his post now is stopped as lecturer at Department of Maxillofacial Surgery at Faculty of Dentistry Hasanuddin University. He was attended a course on temporomandibular joint surgery, Kuala Lumpur, in 2019. Crystal sinus bone augmentation course in World Austin Meeting, Russia, and he was also a speaker on several seminars. To Dr. Gazali, the session is yours.
Yeah. Okay. Thank you, the chairman of this session, Professor Susi. And may I deliver in Indonesia or in English, Prof?
Better in English because it is international conference.
Okay, thank you, Prof. Okay, thank you, Prof. Before I start my presentation, I want to say thanks to our Honorable the Dean of the Faculty of Dentistry, Hasanuddin University, and Head of Department Oral and Maxillofacial Surgery, Hasanuddin Faculty of Dentistry, Hasanuddin University, and the Director of the Dental Hospital, Hasanuddin University. Thank you for support. I as presented for this seminar, international seminar, as a representation from the Department of Oral and Maxillofacial Surgery. Okay, today I want to sharing about I want to share about the my experience about the management to the oral one of the case in oral and maxillofacial surgery. Okay. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Before we take the question, maybe you see my slide. Okay.
Not
Okay.
yet, doctor.
Yeah.
Not yet.
Oh, okay. Can you see the slide?
Siap sudah, dok.
Okay, thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, thanks for your participation in my session today and morning. And I just want to share about the case and one case of the oral maxillofacial surgery during pandemic and COVID-19. It's just a sharing case, my experience case during the pandemic, how to manage the dislocation in this pandemic. The background of this case is the novel coronavirus was identified in Wuhan, China in December 2019, and in January and 9 January 2020, and Wu declared in the discovery as SARS-CoV-2, and the popular name now is COVID-19. The problem about our professional, we professional for the oral for the dental and oral maxillofacial surgeon and the dental professional is the high risk contamination and contact to the exposure to the blood and aerosol and droplet production during the majority of our procedure. And we know the virus can transmission during the dental procedure can through inhalation or aerosol droplet from individual infected or direct contact with the mucous membrane, oral fluid, and instrument and the surface of the contaminant from the surface and instrument. It's the background of why we can explain about the problem now. Okay, according to the Indonesian Association of Oral and Maxillofacial Surgery have recommended to how to manage the patient during the emergency situations. They recommended five case and categorize and the emergency in oral in maxillofacial surgery. The first and the abscess situation, and it can spread to the neck and maybe to the mediastinum, and sometimes makes the patient can open the mouth, difficult to intake the feeding, and maybe sometimes with the odonophagy and with odonophagy she can be swallowing. And the second is the severe pain, as recommended in categories and emergency case. Severe pain without the trigeminal neuralgia pain. It's in categorized the second one. The third is the trauma and the dental and the maxillofacial regions. It's important we manage because it can be because it can be cause a fatal case. And the next, bleeding. Bleeding may be sometimes caused by the with patient with the hematologic disorder. Example, the anemia or thrombocytopenia and X63 or the cause the hematologic disorder, and can the manifestation and bleeding in the gingiva and the oral region, and sometimes with the trauma of the soft tissue in the mouth. We as soon as management with the case and the emergency. And the next is the dislocation of the mandible. Is the mass dislocation if the mandible because maybe she opened the mouth is so wide. It's the categorize the emergency in oral and maxillofacial surgery. And just introduction about temporomandibular joint, maybe you know the mandible is the articulation with the temporal temporal bone and of the cranium. The articulation with the mandible and the temporal bone from the cranium, and the temporal mandibular joint is formed by the mandibular condyle and fighting to the mandibular fossa of the temporal bone and separating with this with the articular disc, separating with discus articular. It provides for high movement of the high movement, as the considered by a ganglioid joint, and sometimes she's as a arthrodial joint and has been technically considered as ganglioarthrodial joint. Because she ganglioid joint and arthrodial joint as a gangli for the movement on the plane and the gliding as a arthrodial joint. It's about the temporomandibular joint. How the biomechanics of the temporomandibular joint is the two part of the important for the biomechanics of the temporomandibular joint. The first one is the system of the tissues of the surrounded the inferior synovial cavity. It include the condyle and the discus, and the second is the made of the condyle discus and functional of the surface of the mandibular fossa. Is here the mandible movement to move forward, refer and to translate. Itu more one for the movement of the mandible. It's the little or the biomechanics of the temporomandibular joint. Maybe you know this. It's just the physiology mechanism of the temporomandibular joint. It's the view of the what about the articular disc fossa, and the part of the mandible is the condyle, and is the part of the temporal bone is the connecting with the discus, discus, and the part of this discus, the conducting between the mandible and the part of the cranium. What about the mechanism of the mandibular movement? We know the 6 mechanism of the mandibular movement. The first is the rotation movement rotations. Is the the rotation is the move from the us, and the next is translation movement. It's important to open and close the mouth. The mouth, if you close and open the mouth, it's the mechanism of translation movement like this, and is the movement are open. When we open the mouth, the head condyle move forward to the eminentia articular. And the next any mechanism is the sagittal plane border is a functional movement, and then horizontal plane border and frontal or vertical border is G of that is a functional movement. And the next is the 3 dimension of movement. The mandible can move any dimension. It's can move in one moment you can move an three dimension. But now what is important this in I explain about the translation movement, the mandible dislocation, translation for the open and close the mouth. The problem is when we open the mouth, we can move to the back. What about etiology and the pathophysiology of dislocation temporomandibular joint? Before that, I explained in the Germany incident is the estimate to be at least 25 per 100,000 population case in the Germany, and the Lowry at all reporting 7 dislocation over the 7 years period in emergency setting at with approximately of the 100,000 visiting in the United States. And Sang et al. Report 29 patients in 10 years study from Nairobi, and same as the Agaba et al. Report 26 patients of a similar period 7 years in Nigeria. It's the incident of the dislocation of the mandible. And I have experience in my medical records of the periodic pandemic COVID-19 in April and until ages 2020. I have managed the patient with 6 patients during the pandemic until this month. This month is but the first patient is he came to the emergency room, and situation pandemic the start of the situation in Indonesia and other global is very situation is very what's the left the curve is the so we will be up female 57 years old come to emergency room, and Undata Hospital. Undata Hospital is one of the satellite as the teaching hospital in Palu, Sulawesi Tengah. In female 7 years old come to the emergency, and I reduce with limited because the situation is not like now, and the situation is very poorly because we not have more personal protective equipment because the situation is for the hospital is not the best, but the patient I must be doing now for the emergency situation. And in May and July, I get 2 patients, female, 42 years old. He came with the situation with the, it have a comorbid disease because he have tuberculosis, chronic, long time treatment, tuberculosis. He come with can close the mouth, less than offer the 5 hours. And the next, the patient is a female, 46 years old, come to the emergency room, and I reduce, and I have the video and picture after that for this patient, for manage the patient. And therefore I have refer from the neurosurgeon in the intensive care units, have a patient with medical history of trauma, and he can close the mouth, open the mouth because the dislocation. My diagnosis is a dislocation, but the history of before the have head injury, but not the but not with the maxillofacial trauma. It's the face on the outer of the soft mucosa. It's clear, but maybe his have of the but for the neurosurgeon is a problem. But the issues, yeah. And patient with the ventilator because the Glasgow coma scale is 9, and patient with the ventilator. And the consultant of the critical anesthesia try to remove, but you can move the mandible. And the next patient is the man, 21 years old. He's a youngest, and come to I call from the emergency room and with the dislocation. But when I come to the emergency room, the mandible is overlaps. But I know before the patient is we take the injection with the diazepam as a marker and muscular relaxant for relax, and the patient is overlaps the mandible. It's the maybe it's categorized as subluxation of the mandible. And the next patient is a female, 20 years old, with I reduce in it with sedation intravenous because is as the 80 years before she come to the hospital. I reduce with the intravenous sedation in emergency surgery room. What about the dislocation is the same as the condition is the subluxation and luxation. Is the during the maximum opening of the lateral of the condyle will jump forward of the preauricular depression, but she can back to the fossa is the subluxation of hypermobility. And occasion is the mouth is open beyond the normal limit, and the mandible is looks in this position, looks, and patient cannot close the mouth as the mandible is look on the anterior of the eminentia articular. This condition is almost always plus wide opening. For example, long dental procedure and yawns. Sometimes it's make the conditions. And is the view of the dislocation position of the caput condyle anterior of the eminentia articular, like this, is the position of the disc is the posterior, the anterior in the position of the caput condyle. Yeah, because the have to position of the discus when the luxation of the mandible, of dislocation of the mandible like this. What about to diagnosis of the temporomandibular joint? We from the examination from the anamnesis for the history of the patient is association with the wide open procedure, for example, such as a long dental appointment, or but may also extend of the yawn of the mouth. See on the maybe sometimes see logging also open the mouth. And what about clinical characteristic is clinically appearance of the patient can open the mouth and can reduce the mouth, can close the mouth, and clinical anterior usually separate with the posterior teeth closed. The patient cannot verbalize. He can speak normally, and problem because is sometimes the patient is distressed and the is not comfort situation and they feel pain. Yeah, because as the situation is make me see face anxious and distress and stress about the situation. It's the clinical characteristic. And is I have a picture about some cases and is the patient of the in patient in the with ventilator can close the mouth and yeah. Okay, it's the situation when the patient come to the emergency room. And the next what is supporting for the diagnosis, supporting examination for the support the diagnosis is imaging radiograph. But in this situation, if the situation is maybe for the difficult to remove in the manual reduce, maybe we try to move the imaging radiographic, such panoramic X-ray like this, position of the condyle, and is the CT computed tomography with in this patient is in the intensive care unit before because he were all the head injury maybe. It's the dislocation, the flattening of the this is a view of the flattening of the discus articular. What's the management and the treatment of the temporomandibular joint dislocations? According to the guidance from the CDC, Center of Disease, recommended for the dental and all procedure in for the dental setting during the pandemic coronavirus. You must because the guidance is the for manage patient and oral and the dental situation in the pandemic of COVID-19. For the important, maybe we use the how to prevent infection and the dental healthcare or the dental and during the pandemic. And recommendation for important is the personal protective equipment PPE for the patient before we do the patient. A surgical mask, the eye protection, Google and the facial, and gown or protective clothing and hand glove. But in the Indonesian Dental Association recommended as a PPA, we move the we go we do the in the all of the dental procedure we do the cover all gown. But I think it's difficult if we do the patient with cover all gown in the emergency room, because in the hospital the management special management, or if the patient if positive COVID-19 or the rapid test is reactive, we protect with the cover all gown. But if the patient is not reactive or the swab is not positive, we do the patient with the level 2 protective personal protective equipment with just the gown without the cover all gown. It's the according to the Susilowati, it's the algorithm of the for acute anterior temporomandibular joint dislocation management. And the patient come to the our center or our hospital. We identify the patient is unilateral dislocation or bilateral dislocation, and if increase of the bite risk and increase of the risk of the infection. If the unilateral dislocation, and yes, we do that recommendation to extraoral reduction. But if the bilateral dislocation cannot increase bite and the situation is be better, we do the now, and can we reduce the patient? We reduce the patient with the outer method without the extraoral. If the extraoral can do, we do the extraoral. Intraoral reduce is we can use the technique OI's private or Hippocratic or recumbent, and the other technique for intraorally approach. But if success, we immobilize and recommended so soft food and pain medication and Aisha therapy. But if for the other situation, is can be removed. Now we recommend the patient under medication muscular with the muscular relaxation of the general anesthesia and analgesic sedation. I have one patient with like this. Out to in the some the journal recommended for management the dislocation is we categorize to the non-surgically and the surgically. What about non-surgically is the manual reduction involve the non-surgical treatment in acute dislocation. The first the method is extraoral reduce. We reduce with the from the extraorally, and to the Hippocratic or the classical method, And when now the Hippocrates is popularly from the Hippocrates method. And the next, the Weiss pivot methods, popularly from the Weiss pivot, and the recumbent methods, and the next is shearing method. Other method is the with injection with the botulinum toxin, but I not include in this presentation. And the next, surgically approach. The surgical approach, if the especially for the recurrence dislocation and acute and chronic or recurrent dislocation. For chronic, we can recommend patient for the chronic dislocation, recommendations for the surgically and minectomy, condylectomy, and special osteotomy technique. On the outer technique, surgery for the temporomandibular joint. It's the view of the picture of the Hippocratic method. The position of the surgeon, the dentist, or the operator is the front of the patient. Is the you see there's a high risk because the patient face to face with the operator. It's not be, and the first is the in the situation is not be better because the patient is very close with the patient. It's a Hippocratic method. And next, it's the recumbent methods. Recumbent methods is uh, the position of the operator is the back of the head, the back of the patient, not on the front of the patient, but the back of the head, the patient, like this. And maybe we can distance with the patient, not very close. We can distance with the patient position, operating with distance from the patient, but we finger is put into the orally. As the rice pivot methods, like this, same with the Hippocratic method. The operator is the anterior, the front of the anterior of the patients. Same with this, the extraorally. The patient of the and the operator is the front of the patient too. It's not in situation maybe it's not better in recommendation because it's very high risk. Okay. And next, the shearing methods. In this is difficult because is all of the remove the any as of the patient, all for the patient, not intervention of the operator. The the patient the activity, all of the reducing activity by the patient only, not with the intervention by the operator. In situation is difficult because patient is not a pain and anxious and very situation is not be better for the instruction for the open and close the mouth in when situation pain situation. I have a picture in like this when I reduce the with the recumbent technique for the patient in eye intensive care units, and this with the sedation in intervene with intravenous sedation in the emergency room surgery. Uh, okay, I have a video when I reduce the patient with the recumbent technique. Is the other patient with the comorbid with the tuberculosis chronic and the long treatment and situation is very poorly. The nutrition status is the poorly very yeah. And I reduce in the emergency room. I use the minimal PPA. I use the gown with the face shield, surgical mask, and the head cap. It's the because hospital just have that PPA for in emergency room. Okay. What about the supporting treatment after we remove the mandible on the position? We use the bandage or head elastic bandage, immobilization with the bandage, head chip cap of the elastic maxillary intermaxillary fixation for the 40 and 80 hours. And immobilization to limit the maximum opening of the mouth 1 until 4 weeks to prevent recurrence of the condition. And the manual reduction, sometimes we can attempt without the administration any medication because maybe we without any medication is unsuccessful and we made by under medication. For example, muscle relaxant and or analgesic. Analgesia is I recommended to use because the patient is very sometimes is severe pain. Like for pain maybe I have 6 or 7 pain or sometimes is severe until the 10 leveling of the pain. But sometimes we under the analgesic sedation or the general anesthesia. For the example, I use the analgesic sedation with the intravenous sedation. With I think the anesthesia use the ketamine and the fentanyl for the prepares as analgesic sedation. Is immobilization patient after use a head or bandage, elastic bandage. And as a conclusion of my presentation today, which the treatment has been best changed the success of the dependent on the factor, including the pathogenesis of the case, age of the patient, sometimes secondary diagnosis include the comorbid disease, compliance, and treatment goal and care instructors, care structure, and among other. The best treatment for each individual patient will be determined based on true medical history, yeah, and physical examination, and we try to minimally contact face to face for the long time. And recumbent method is one of the recommended method in pandemic or for the future, for the new normal situation. Maybe they can be recommended as one of the best method for reduce the dislocation of the temporomandibular joint. Yes, I have experience for the less than 5 years. 5 years, I use the recumbent technique and for reduce the dislocation of the mandible. Okay, thank you for your attention, and I back to the chairman of the session. Thank you.
For Dr. Gazali, who has delivered his experience and expertise interestingly. Now we come to the question and answer sessions. Anyone who want to ask any question, please write down your question in the Q&A box. The first question is from Ina Ibnu. I will ask you what about using the head bandage for your patients? Are they still need the control after the procedures during pandemic? Thank you.
Yeah. Okay. Thank you for the ask. I want to answer the question. The patient have use on the head bandage for the patient, but all of the patient can back to controlling during the. But I instruction for the patient to 46 hours can the by herself to open the bandage or the because it's and the other instruction instruction for the patient or to diet food diet soft food diet and limiting to the open the mouth if he open the mouth is or keep is limited and for the open the bandage it's by the patient or the family not come to because the patient is I think not come controlling because after it maybe I know maybe the patient is afraid to come to the hospital in this situation pandemic. Okay, maybe it's the mungkin saya bisa bantu pakai bahasa Indonesia bahwa pada pasien-pasien ini juga memang situasi ini rumah sakit kan masih membatasi kunjungan. Mereka datang hanya ibarat situasi emergensi, sedangkan pelayanan poliklinik belum ada. Jadi pasien itu datang, ya kita instruksikan semaksimal mungkin pada pasien untuk bisa dilakukan sendiri di rumah sama keluarganya untuk membuka sendiri. Elastis bandage kan tidak susah. Ya, kecuali kita pasang intermaksilarisasi pakai IMF, pakai akbar, mungkin akan sulit kalau dilakukan sendiri. Tapi kalau bandage, saya kira bisa dilakukan sendiri oleh pasien. Selama ini bisa. Kadang mereka dengan gerakan tersendiri juga bisa terlepas kalau mereka bisa ini. Ya, oke. Demikian. Mungkin nanti untuk residen, ya. Tapi untuk residen bedang mulut, saya sudah siapkan ada video. Ini untuk kayak semacam JSL ada video untuk TMJ ini untuk dislokasi ada saya nanti di mungkin di sekolah mungkin di upload untuk teknik dislokasi reposisi dislokasi yang secara lengkap lagi mungkin ada di situ untuk residen bedang mulut PPDS bedang mulut. Okay.
The second question is from Faisal. What are the differences and considerations that should be seen from the treatment of patients with mandibular dislocation in patients coming from the ICU with the GCS9, and what is the etiology of the dislocations in this patient?
Yeah, okay. Different between the normal situation and the GCS9 in situation is because in patient in ventilator, they have muscle relaxant and under and between and under intervention of anesthesia medication. Yeah. It's easy for reduce because see the have a give a muscle relaxant and situation is patient is not jadi pasien tidak ada rasa menolak, dia tidak menolak lagi, jadi lemas, benar-benar lemas untuk di remove. It's so very sangat lemas untuk dilakukan. Jadi situasi berbeda dengan ini pasien masih sadar, pasien akan sedikit merasa berteriak, kesakitan, ada rasa respon balik dari pasien. Tapi pada situasi ini pasien tidak, jadi lebih mudah redusnya. Dan itu yang secara teknis. Tapi secara mekanik, si mekanik teknik is dari gambaran CT-nya, pasien ini sudah eminensi artikulernya sudah flat. Artinya dia sudah punya kondisi yang recurrent sebenarnya. Mudah sekali untuk balik dan kembali lagi untuk jadi dislokasi. Kondisi recurrent ini memudahkan pasien itu untuk harusnya mudah kembali ya. Harusnya mudah. Tapi ternyata sama dokter teman-teman di ICU tidak bisa mengembalikan. Termasuk dokter waktu itu dokter anestesinya juga sudah mencoba, mereka tidak bisa kembalikan, mereka konsulkan. Jadi ini sebenarnya justru menurut saya lebih mudah. History of the patient itu ada riwayat trauma. Traumanya cuma trauma di daerah sekitar batang otak. Jadi waktu ada benturan ditabrak dari arah belakang, tabrakan dari arah belakang mungkin tersentak. Jadi ada sedikit cedera sedikit di daerah tidak sampai ke kepala. Pasien tidak jatuh secara seperti trauma maksilofacial biasa. Jadi hanya ada cedera kepala tapi langsung disertai penurunan kesadaran. Mungkin ada hentakan yang tiba-tiba dari sekitar cervicalnya, mungkin hentakan yang tiba-tiba membuat pasien berespon pada kesadarannya. Karena pasien sempat mengalami penurunan kesadaran, makanya dirawat di ICU sampai GCS-nya hanya 9. Ini situasi yang membuat pasien, jadi pasien tanpa cedera wajah, cedera kepala yang berat, tidak ada perlukaan, tidak ada jejas dan sebagainya. Dia dengan riwayat trauma ditabrak dari belakang, motornya ditabrak dari belakang. Okay, maybe it's the answer of the from the Faisal.
The next question is from Arwini Wulandari. Thank you for the nice presentations, Dr. Gazali. I want to ask about consideration and the techniques we can use for the patients with TMG dislocation and confirmed COVID-19 with critical condition.
Yeah. In critical condition, I recommended the patient is with the best technique is a recumbent technique because it's not difficult. Jadi tidak susah kita melakukan, apalagi dengan kondisi-kondisi pasien yang seperti pasien kritis kan biasanya banyak alat-alat yang ada di sekitarnya. Kalau kita lakukan posisi teknik-teknik yang lain itu tentu agak sulit. Manipulasi itu harus hati-hati karena the manipulation is cost many equipment of the critical situation. Banyak alat-alat, ada ventilator, ada monitor dan sebagainya, banyak kabel-kabel yang terpasang pada situasi membuat sulit kita model posisi. Daripada posisi recumbent, dari posterior justru lebih bebas. From the back of the head, the patient is free from the many equipment. Because sebab dia punya alat-alat yang lain berada di sisi kanan kiri pasien. Ya, itu mungkin. Jadi saya rekomendasikan mungkin teknik recumbent ini yang mungkin kita bisa selama ini saya gunakan hampir semua pasien dislokasi saya reduksi dengan recumbent karena itu justru lebih mudah. Apalagi posisi kepalanya tinggal kita posisikan secara maximal extension of the head position. Jadi kita maksimalkan posisi kepala dengan ekstensi maksimal akan lebih memudahkan karena ekstensi maksimal dari kepala akan menarik mandibula ke arah belakang. Jadi kita hanya mendorong satu ke bawah, otomatis ototnya menarik sendiri karena posisi ekstensi ini. Sama dengan kita membayangkan kalau pasien diintubasi oleh anestesi akan bergerak pada saat intubasi setelah lemas. Itu mandibulanya karena bergerak. Nah, pada saat begitulah kurang lebih seperti itu. Gerakan seperti itu memudahkan dia kembali ke fosanya. The movement of the dengan kalau misalnya kalau anestesi menggunakan ini blade ininya untuk intubasi, blade-nya kita menggunakan jari. Yang penting posisinya itu harus ekstensi maksimal. Oke.
Okay. The other question is from Muhammad Hidayat Rusdin. Thank you, Doc. I want to ask you about management of patients with recurrent dislocation of the MG more than 3 times. Is there any procedure?
Oh. Untuk for the recurrent condition is difficult. Saya juga punya pengalaman tentang recurrent ini, sebenarnya cukup repot. Kadang pasien baru selesai, apalagi disertai dengan kelemahan dari otot-otot, pasien post stroke misalnya. Pasien pasca stroke itu sulit kadang, dia tidak bisa mengontrol otot-ototnya. Saya pernah punya pengalaman pasien baru selesai saya reposisi di poliklinik, pasien balik ke rumah kembali lagi. Jadi belum saya pulang ke rumah, belum tutup klinik, pasien balik lagi karena kembali lagi. Walaupun sudah dilakukan, sudah difiksasi. Jadi memang kondisi itu sulit karena memang sudah ada kelemahan dari otot-ototnya. Makanya ada beberapa teknik yang biasanya direkomendasikan, diantaranya sekarang ini penyuntikan dengan botox. Botox itu tapi sifatnya juga tidak permanen. Harusnya ada intervensi surgical intervention untuk pasien ini. Jadi apakah kita menambah ketinggian kita imunoplasti, menambah eminensi artikularnya, kita tambah tingginya, atau kita lakukan prosedur yang kita lebih nilai, kita ganti ininya, kita ganti sendi artroplasti, langsung diganti sendinya untuk supaya tidak terjadi lagi posisi yang ini. Jadi itu teknik yang, tapi itu mungkin teknik yang lebih untuk pada kasus-kasus tertentu sulit karena pasien usianya rata-rata sudah high risk, comorbidnya sudah banyak. Jadi mungkin yang bisa ini dilakukan dengan penyuntikan, beberapa jurnal menyuntikan penyuntikan botox untuk, tapi itu hanya temporer. Mungkin 6 sampai 6 bulan kemudian akan relapse lagi. Penyuntikan dengan botulinum toxin ini. Okay.
Okay, the next question is from Rahmadi Novriansa. Assalamualaikum. Thank you, Doc. I want to ask you about how to choose method for every patient dislocation case. Is there any indications in the patient?
Ya, saya nggak ngerti maksudnya. I don't know what the meaning of your question. How to choose method for every patient dislocation case. Yeah, it's about the etiology of the patient. Maybe we can separate for the chronic, acute, and recurrent patient. For the acute condition, we can use the method is the Hippocratic and recumbent. I recommend the recumbent and Hippocratic or Hippocrates or classical method. It usually many center use the technique for the use, and sometimes kadang kita juga gunakan teknik yang lain tapi agak sulit karena kita the other reduce, misalnya yang paling sederhana itu teknik ekstraoral, tapi itu pengalaman operator yang lebih menentukan. Sebenarnya ini banyak ditentukan oleh pengalaman operator karena pengalaman saya, semua pasien yang saya tangani itu sudah dilakukan reposisi oleh teman-teman yang lain, terutama di IGD. Teman-teman dokter UGD itu atau perawat-perawat UGD biasanya sudah melakukan reposisi, sudah melakukan tindakan. Jadi mereka tidak datang langsung konsul, tidak. Mereka sudah mencoba, karena saya juga sarankan begitu. Mereka coba lakukan reduksi dulu, baru di ini. Tapi rata-rata mereka, yang saya sebutkan semua ini adalah yang tidak berhasil mereka lakukan reposisi. Jadi saya lakukan reposisi karena mereka itu. Jadi tidak sesederhana, emang teknik ini tidak sesederhana yang kita lihat. Nanti pengalaman kita, jam terbang kita dalam mereduksi ini akan menentukan. Pengalaman saya juga waktu di Bandung lalu, waktu masih residen di Hasan Sadikin itu, begitu banyak residen yang ada di IGD, ada dari bedah, dari sebagaimana macam-macam. Malah biasanya kalau pasien baru itu ditangani oleh PPDS bedah dulu, nanti baru nggak bisa, baru ke bedah mulut. Tapi begitu juga, artinya mereka dengan jenjang pendidikan begitu, maka tidak mudah juga mereka mengembalikan dari resident junior ke chiefnya, tidak bisa mengembalikan. Artinya tidak sesederhana, tidak semudah yang kita lihat, tanpa kita nanti akan kita dapat touch-nya. Bagaimana teknik rekamban itu yang posisinya yang paling enak. Akhirnya dengan mudah kita bisa reposisi. Dan kedua, kondisi waktunya ini juga misalnya sudah cukup lama, misalnya seperti terakhir pasien saya sudah 18 jam. Spasme tidak bisa dihindari. Kondisi spasme akan mempersulit reduksi secara manual. Kondisi spasme tidak bisa kita hindarkan pada pasien-pasien yang sudah lebih dari 18 jam itu sudah mulai spasme, sudah mulai inflamasi, terjadi inflamasi di otot-otot sendinya dan di masticatori muscle-nya, di otot-otot pengunyahannya. Sudah mulai spasme. Jadi kita walaupun pasien tidak melawan, ototnya sendiri sudah membuat reaksi untuk melawan. Makanya kita lemaskan dengan pemberian muscle relaksan dan malah kita berikan sedasi analgesi untuk melemaskan semua kondisinya agar kita mudah mereposisi. Jadi waktu, kalau masih pengalaman saya di bawah 6 jam itu enak sekali. Tapi pernah saya juga dapatkan kasus sudah lebih dari 24 jam. Mudah juga saya reduksi, bisa saya kembalikan ke posisinya semula. Jadi mungkin for our resident in Department or Maxillofacial Surgery, maybe sometime we can discuss of this case more because I have many case about the dislocation of temporomandibular joint. Okay, thank you. Prof.
Any more questions from the participants? Okay, if there's no any more questions, in my opinion, Dr. Gazali has referred his presentation very interesting because there are so many questions and he answered very well too. And now, thanks again, Dr. Gazali, and I will return the time to the committee. Dr. Yossi, you will receive the certificates through email, maybe. Yossi? Yes.
Prof, I'll take over the session. My representative for Dr. Yossi. The certificate going to send to your email, Dr. Gazali.
Thank you. Makasih.
Yeah.
Okay, ladies and gentlemen, finally we come to the last agenda. We would like to say thanks again for the presenter and all of the participants today. Thank you for your attention. See you later, and I will return the session to the committee.
Thank you, Dr. Susi, and thank you for all speakers in 7 session for the nice presentation and explanation. Okay, thank you, Dr. Gazali. Thank you, Prof. Susi. And okay, ladies and gentlemen, distinguished participants, let me, Dr. Gigi Israyani, as the master of ceremony for this session, to lead this event. We are now going to 8th session of the 4th International Conference on Biophysical Technology in Dentistry, and this session will be led by the moderator, Professor Dr. Gigi Fajriani, M.Si. But before we going to the 8th session, we want to show you the video. Please check it out.
Sensodyne Repair and Protect is a daily toothpaste for the treatment and prevention of dentine hypersensitivity. Sensodyne Repair and Protect contains Novamin, an advanced calcium and phosphate bioglass technology. A single Novamin particle ranges from about 5 to 20 micrometers in size. New Sensodyne Repair and Protect also contains sodium fluoride. The unique formulation has been developed so that both the Novamin particles and sodium fluoride are protected in their active form and available when brushed with in the mouth. When Novamin comes into contact with saliva, it releases calcium and phosphate ions to build a hydroxyapatite-like layer over and within the dentine tubules. This begins with an ionic exchange between sodium in the Novamin and hydrogen ions from the saliva. This ionic exchange causes a small localized rise in pH that promotes formation of hydroxyapatite. Novamin particles can bind to collagen fibers in dentine. Once deposited, these particles continue to react and act as a calcium and phosphate reservoir to build a hydroxyapatite-like layer over dentine and within the dentine tubules that also incorporates fluoride. This hydroxyapatite-like layer is chemically and structurally similar to biological apatite, forming the inorganic portion of dentine. The reparative layer formed by Sensodyne Repair and Protect starts to form after the first brushing and promotes the dynamic mineralization of dentine to build a substantive reparative layer over the dentine and within the tubules, which in turn reduces dentine permeability. Decreased permeability can relieve dentine hypersensitivity by decreasing the fluid flow within tubules, thereby reducing the activity of nerve endings. Sensodyne Repair and Protect delivers clinically proven relief from the pain of dentine hypersensitivity with twice daily with Repair and Protect.
Okay, thank you for the videos. Next, we're going to enter the 8th session that will be led by Professor Dr. Gigi Fajriani, M.Si. So before I introduce her, for all participants, if you have any question, please type and insert in Q&A below in the box. Okay. All right, a brief introduction of the chairman, born in November 30th, 1969, graduated her dentist degree, magister, and doctoral from Hasanuddin University. She is currently a lecturer staff of Periodontic Department in Faculty of Dentistry, Hasanuddin University. She has a lot of research and publication, and the newest of the publication with title is the Effectiveness of Gargle Content Extract of Moringa oleifera leaves to inhibit plaque formation on early childhood caries in International Journal of Applied Pharmaceutics in 2019. So for the Professor Fajriani, the time is yours.
Okay. Thank you very much to MC, Dr. Israyani. Assalamualaikum warahmatullahi wabarakatuh and good morning. Ladies and gentlemen of the seminar, we will enter the next session.
Waalaikumsalam warahmatullahi wabarakatuh. Prof. Fajriani.
Marhamah. All right. I professionally wanted to say hello The first presentation, Aisha Hussein Al-Jamaei, DDS, M.Si, Ph.D. Hello, Dr. Aisha.
Hi, good morning.
Good morning, Doctor.
Indeed, it is here. It's still not, it is 4 a.m. So, okay.
Okay, thank you. The second speaker, Dr. Marhamah, M.Kes from Hasanuddin University. Hello, Dr. Marhamah.
Halo, Prof. Ajriani.
Thank you.
Thank you very much.
Okay, all right. Next, I confess some of the profession of this event. The speaker was given 4-5 minutes to present their paper. The question and answer session will be given 15 minutes after the speaker present his paper. If you have a question, you can send a write message via the Q&A column. All right, before that, I will read the curriculum vitae of the speaker. Name Aisha Hussein Al-Jamaei. He lives in Amsterdam. Educational qualification, Doctor of Philosophy in Oral Oncology, University Amsterdam, Academic Center for Dentistry Amsterdam, the Netherlands. The thesis title, Oral and Oropharyngeal Squamous Cell Carcinoma Epidemiology and Target Treatment. And relevant course, Oral Biology, Advanced to Flow Cytometry, Oral Biology, Basic Microscopy, Radiation Oncology, Statistics and Methodology, Scientific Writing and Presentation. And then European Diploma in Oral Medicine in Sweden, Master of Science in Oral Medicine in Jordan, University of Science and Technology Irbit Jordan. This title, the thesis title, the relationship between oral hygiene and candida colonization in health adult subject. Bachelor of the Surgery, year 2004. Technical experience, mammalian cell culture, viability and apoptosis assays, flow cytometry, Western blot, immunofluorescence, microscopy, immunohistochemistry. And clinical experience, July 2016 until July 2017, working in oral medicine clinic, VU Medical Center, Amsterdam. And employment experience, lecture on oral medicine and pathology department, Sana University, giving lecture oral histology, pathology, and oral medicine, training, how to do clinic examination, what investigation should be required to reach the correct. Conference presentation, World Congress, the International Academic of Oral Oncology, Italy, and many scientific publications to sort in the time only read of you them. Review of the much promising biomarkers for early diagnosis and prognosis, prediction of tongue squamous cell carcinoma. All right, the next, we invite the first speaker, Aisha Hussein Al-Jamaei, DDS, M.Si, Ph.D, to present paper entitled Biomarkers that most promising for diagnosis and prognosis prediction of tongue squamous cell carcinoma. Please, Dr. Aisha.
Thank you. Can you hear my voice clear or?
Yeah.
Okay. Okay. Good morning, everyone, and thank you so much for the invitation. My talk today is about the most promising biomarker for early diagnosis and prognosis prediction of tongue squamous cell carcinoma. Why we were interested in biomarker and especially for tongue squamous cell carcinoma, hopefully the background will answer this question. Cancer of the oral cavity is one of the most common, is one of the top most common cancer globally. In some country, even it ranks among top 2 or among top 3. So it is a serious problem. For 2018, the most recent year for which Globocan data was available. For those who don't know Globocan is the online database or platform. It is interested in collecting the cancer incidence and survival from cancer registry all over the world. And in 2018, the data showed over 300,000 patient diagnosis with oral cancer. As most of you know that the most common histology of oral cancer, of course, is squamous cell carcinoma. And why we focus on the tongue, here are some of the reasons. In the oral cavity, in a population-based study conducted by Keng-Liang and co-authors, they evaluated the oral cavity cancer in developed and developing country, and that study included 180,000 patients. And the study found the tongue was the most common involved anatomical site for squamous cell carcinoma with 41%. Equally important, over the last 3 decades and in parallel with a decrease in tobacco smoking, a significant reduction in the squamous cell carcinoma affecting different anatomical structure of the oral cavity has been noticed in some Western countries, especially in the United States and Canada. Except for the tongue, especially for the anterior part of the tongue, that showed a marked increase, and this increase was also profound in the patient younger than 45 years without any unknown reason. Even though we all know that oral cavity and the tongue is actually it is inaccessible. I mean, any changes in this location can be noticed by the patient or by the dentist to see if there is something suspicious. But unfortunately, the tongue squamous cell carcinoma is, as a disease, is comparatively silent, and it progresses from a pre-malignant state into the invasive carcinoma without any alarming symptoms. This causes delay in diagnosis and eventually may lead to a poor prognosis. Finally, even with introduction of the targeted therapy and the advances in the radiation technique and a lot of things and the combined treatment, the 5-year survival rate of tongue squamous cell carcinoma is still unsatisfactory. One important reason for this is the aggressive clinical behavior in which and the high propensity of this kind of cancer to invasive to local invasive, in which 40% of the patients have cervical metastasis at the initial diagnosis. Therefore, there is a great of interest in finding a biomarker that because it has a potential to enable early detection and provide other information that might help the clinician to discover this disease as early as possible and also help in diagnosis, and both will lead finally to improve the prognosis of the patient. Luckily, nowadays there is, because of the huge improvement in high throughput technology, there is a good understanding of the cancer development and progression. and knowledge, especially about regulatory pathway and signaling interaction, either between the tumor cells themselves and between the tumor cells and between the microenvironment that lead to neoplastic transformation has been gained. So delineation of this pathway has revealed a multitude of biomolecular changes. So following these molecular changes, following this pathway has revealed a lot of biomolecular changes, and just studying or focusing on these molecular changes lead to identified a lot of biomarkers. So the biomarker, by definition, is an objective measure such as a gene, a protein, enzyme, or hormone that can reflect the entire spectrum of the biological or pathogenic process or pharmacological response to the therapeutic intervention. There are several definitions, but this is the one of the most important definition, and this is from, it is called from a biochemical point of view. In clinical utility, I mean, for the clinician, the biomarker can be defined as a measure that might help in evaluation the risk of developing a cancer, or evaluation the risk of progression or the potential response of the treatment. The good thing about the biomarker, it can be detected in a lot of tissues, different kinds of samples. It could be detected in circulation, it could be detected in secretion. And both type is referred to body fluid biomarker or liquid biomarker. And indeed, this is the main reason for a lot of cancer research or university to start establishing what is called liquid biopsy biobank or liquid biopsy center, and also it found, of course, in tissue samples. The people or the scientists who are working in the cancer biomarker have both several criteria to define the ideal cancer biomarker. So the ideal cancer biomarker is the biomarker that produced only by the tumor cells. I'm sorry if I am a little bit fast. It also presents in measurable quantity in the patient, but undetectable in healthy subject. The third characteristic of this ideal cancer biomarker, it should be cost effective and is easy to measure and non-invasive. Finally, the ideal cancer biomarker, it should have 100% sensitivity and 100% specificity. Of course, this is a little bit not 100% achievable, but yeah, still the researchers are still trying their best. As I said earlier, the biomarker is a reflection for the biological or for a pathogenic process. So it is usually associated with the stage of the disease. So the biomarker, because of that, there are several types of biomarker that could be used also in different clinical settings. The biomarker, for example, could be used before the cancer development, and so it is called the risk assessment. So it can indicate which subject will develop cancer in future, and in such a case, these subject could undergo either preventive program or screening. It could also, we have a diagnostic biomarker. A diagnostic, it tell us this patient have the disease and this one doesn't have it. And this is important also because sometimes the cancer, it is not, the clinical picture, it is not that clear. So having a biomarker, it will also be useful for diagnosis. After the cancer diagnosis, we have different type of biomarker. The first one is the prognosis. Prognostic biomarker is a factor that predict which patient have a good prognosis and which one have a poor prognosis. This is before starting any kind of a treatment. So based on that, if we have a prognostic biomarker and we determine this patient have a good or a poor prognosis, the treatment plan will based on this I mean, the treatment planning can also be decided based on this kind of biomarker. Predicting biomarker or predictive biomarker is the biomarker that predicts whether the patient will respond to the treatment. In another way, or in another word, it means what is the optimal treatment for this patient. We have also one kind of biomarker, it's called pharmacodynamic biomarker. And this kind of biomarker, it is useful to indicate to study the drugs. How is the response of the body to the medication? What is the optimal dose? What is the toxicity? And also it is very useful to study, as you might heard about, the resistance, and it is a very big issue right now in cancer treatment. It also the biomarker could also be useful in monitoring whether the treatment is helpful or useful for the patient, or it doesn't. In such a case, you might the clinician might change the treatment at all. It also we have what is called in case of recurrence, discover whether there is a recurrence of the disease or not. Although the biomarker is now considered as an integral part of the cancer research, but the developmental process of the biomarker from we said from the bench side, from the bench to the bed side is very difficult and is very challenging process. Because of that, in the United States National Cancer Institute Early Detection Research Network has introduced a guideline. This guideline is imaginary, consists of 4 phases, but indeed they are sometimes there are a lot of overlap between them. These 4 phases is phase 1. They classified into 4 phases. Phase 1, it is called preclinical exploratory studies or discovery study. And phase 2, it is clinical assay development. Phase 3, it is retrospective longitudinal study. And phase 4, it is prospective screening study. And also you might find in another article, they divided also this process into 5 stages. As I said, this is imaginary classification, but this is to simplify the process of developing the biomarker and to make it easier for the people who are working or start working in this field to understand what is the process indeed. Phase 1, because when we start working on this paper, and we have tried to find to which phase the tongue squamous cell carcinoma biomarker study reach. Actually, we found most of the study we are still in this phase, so most of the focus will be on this phase. So preclinical exploratory study are performed to identify one or more promising biological biomarker. So it is because of that, it is called the exploratory or the discovery study, the discovery phase. Usually in this phase, the sample is taken from the patient and from the subject, and they are compared to see whether this biomarker can show a discrimination clearly between both. In such a case, we can say we have a promising biomarker or we don't have it. But usually the approach before studying the biomarker, there are usually 2 approaches. I mean, how someone can decide which biomarker I can choose in order to study. So the approaches to choosing either to choose the biomarker by the researcher themselves, and this is through the literature and the background they have, or through right now we have this through high throughput technology like proteomic and genomic, and this study mean just scanning the sample and whatever you have of the expression, the high expression of one biomarker, you can go forward and study it. Since I said this, the biomarker development is a very long process, and it consists of several phases. And so that's mean succeeded in one phase, you can succeeded in the first phase, that mean you can move to the second phase, and succeeded in the second mean moving to the third, and finally this is will mean we will have a clinical, a robust biomarker in the clinic. So in order, because this preclinical exploratory or discovery study is the first or the basis for the other phases, so there are some requirements in order to ensure it is successful. The first requirement, the number of the samples. There should be this based on a Bauer study, and there should be a clear inclusion and exclusion criteria. The third requirement, complete and transparent reporting of the result, and I will explain this later, just focus on this one. This is validation of the finding in an independent data set by independent investigator. What does it mean here? Validation, I mean validation of the finding in independent cohort of the patient by independent investigator. It means confirming the finding by different investigator on different group of the patient. This is what we call the validation. So our main study, and because of that, the third requirement mean complete and transparent reporting, because here, I can simplify this. What I mean here, for example, if one study has been conducted in Indonesia, for example, and one of the biomarkers have shown a potential of discrimination between the patient and between the healthy subject, this kind of study, because it is just one single study, it means nothing. And so that this study has to be repeated or replicated in another country or in another city by different investigator and in different patient. In such a case, this replication study has confirmed the same result. This is mean the study has been validated. Because of that, we said complete and transparent reporting. So the first researcher in any biomarker, they should be transparent reporting what is the method they follow, what is the inclusion and exclusion. So everything should be clear in order to allow the repetition of this study and replication in order to finally we can go forward and moving this biomarker into the clinic. And this was our aim of a study. We aim to list the published literature on both liquid and tissue-based biomarker in tongue squamous cell carcinoma, and our focus was on biomarker whose clinical significance was described in at least 2 independent studies. Indeed, that means we were looking for the biomarker that have been validated. The material and method, we have, of course, we have search in PubMed and in Base. This is the most common engine used. And we have used a combination of the keywords, as you have seen on the screen. So we used a different kind of biomarker and on different samples. But indeed, because we, when we have searching the PubMed and in Base, we have found a lot of replication between both, and unfortunately, even the study that was unique in Base, we excluded them during when we because we have including and exclusion criteria, and most of the criteria that the study have in Base that didn't reach to our goal, so we excluded. We didn't include in Base in our research. So the most important criteria for the selection of our study is study that reporting a clinical significance important for this biomarker. It means the biomarker showed a discrimination. For the exclusion criteria, of course, the study has several additional criteria, but here I'm showing you only the most important ones. the exclusion criteria study that investigated a biomarker in different anatomical subsite of the oral cavity because we would like to avoid heterogeneity. We have adapted here what is called definition level of evidence for validation. We have this have been taken from another study. We have classified the study and the biomarker into 4 criteria. Negative mean the biomarker showed no association. It means the biomarker failed to show any discrimination. Weak level of evidence mean we have found only 1 study that showed a potential of discrimination. Intermediate level of evidence, it mean 2 study consistently showed a potential discrimination. Strong, that's mean more than 3 study showed a consistent discrimination between the healthy subject and the patient. So when we come to define what are the promising biomarkers, the biomarkers with intermediate and strong level of evidence were considered our main, were considered as the promising biomarker. When we extracted the data, because we were, this is just to make it easier for anyone who might go and read the paper, we divided our biomarkers or our study into body fluid and tissue-based. And in tissue-based, we divided also the study into based on the type of the molecules that has been tested or investigated into protein, long non-coding RNA, and DNA. And in the table also, or during extraction the data, we divided our study from the beginning to make it easier. Group A, that is refer to negative or included the negative and weak level of evidence. And group B, it included the intermediate and strong level of evidence, and this was our main target. This is how we divided the table. Since a biomarker is a very sensitive issue, and it was necessary also to do what is called quality assessment. Quality assessment, also the good thing, there is a guideline is specific for the biomarker studies. So it is consists of different checklists, and these checklists will tell us at the end whether this study has a good quality or low quality. So, as I said, the biomarker study in general has a specific guideline for quality assessment, and these guidelines also divided based on the type of the biomarker studies. So in prognostic biomarker study, there is what is called remark. Remark, it is a recommendation of marker of prognostic study. It consists of 20 items. And we have also what is called STARD. STARD, it is a guideline checklist that is specific for diagnostic study. So what we did, we evaluated the study based on fulfill this the items. And then we classify the study either to high, average, or low quality. Our results. Based on our on the searching, we identify at the beginning 1,429 study, but finally we included only 96 studies. We have in body fluid, as I said earlier, that I divided the study into body fluid and tissue. In body fluid studies, I have 13 studies, 5 for early detection, 7 for prognosis, and the other, I think it is just 1 for prognosis and for detection and prognosis. The tissue-based study, it's included 38 study, 83 studies. included immunohistochemistry and long non-coding RNA and DNA. So in total, we have 72 study that is classified as a group A. That means in this study include study with level of evidence weak and negative, and only 24 study that were classified as group B. The sample size used usually varied between, depend on the group. In group A, between 4 and 200. For group B, between 17 and 250 almost. In quality assessment, majority of the study showed average rating, except long non-coding RNA study, because most of this study is just a recent study, so they follow the same. They were aware of the criteria, so during their reporting, what they have done, they follow the criteria very well. The included study examined 150 biomarkers, 23 markers in body fluids, and 127 markers in tissue. Among the study, only 22 biomarkers were evaluated in 2 or more independent studies. That means only 20 biomarker has been validated. But among these 22, only 10 marker demonstrated consistent association between their presence or their expression and specific clinical outcome. And these 10 are the main promising biomarker that we have concluded. So this is the chart. We have the promising biomarker. This is the total. This is the final result of our paper. The promising biomarker in tongue squamous cell carcinoma in body fluids, we have 3 markers. It include 2 cytokine, interleukin 6 and interleukin 8, and the prolactin. While in the tissue, we have in immunohistochemistry, we have 4 markers. We have in long non-coding RNA 1 marker, and in the genetic, we have 2 markers. This is the most important marker that we have seen. This marker has been validated and showed a consistent association, so they are potentially very promising. The discussion, these biomarkers have demonstrated clinical different values. So some of them could be used for detection, other could be used for prognosis. Interleukin 6 and interleukin 8 have been found to discriminate between the patient with a very good, with excellent sensitivity. And so we think they are very useful for early detection. But the problem with these 2 biomarkers, because they are pro-inflammatory cytokines, so they could be expressed for any reason in the body. So we think a lot of effort should be done on this biomarker, especially because they showed an excellent sensitivity. So a lot of further effort should be done on this biomarker in order to define a reference point that can at least tell us this is just inflammation, while this is indicate there is a cancer development. It is well known that multiple level of molecules, as you know, the cancer, it is not that simple process. It is one of the hardest pathogenic process. So a lot of it's called like an orchestra of molecules working together in either to prevent or to promote the cancer development. So we found in the literature a lot of focusing and a lot of attention usually paid to immunohistochemistry. Immunohistochemistry, that means the main focus is only on the protein. And it is surprisingly, maybe you we surprised when we have found a paper that described there are over 500,000 paper study in immunohistochemistry, but among this huge number of the study, there are not biomarker that is useful now in the clinic, except that is epidermal growth factor that is used in colorectal cancer. And beside this, focusing on the protein expression in immunohistochemistry, it could be also insufficient or misleading because as you might know, is the protein itself, it has usually it's go a lot of modification. It is called post-translation changes. It might undergo acetylation or phosphorylation or something that can change its epitope, so it will not be discovered at all. Therefore, it is important in studying a biomarker for a cancer to rely on a group of various molecules rather than just focus on one single marker. Our conclusion is we shed some light on tongue squamous cell biomarkers that demonstrated a consistent association between their expression and specific clinical outcome, at least in 2 publications, and this is what we called the promising biomarker. We have found, unfortunately, 2/3 of biomarker study haven't yet been validated. It mean just we have found most of the study have been, 2/3 of biomarker has been described in 1 publication. Finally, further research on these 10 promising candidates, either separately or in combination, could provide a real new possibility to develop a panel of biomarker that might enable early detection and prognosis for this lethal disease. This is our review, has been published in British Journal of Cancer. So you might, if someone of you is interested, might search for it. And thank you. And any question, I'm ready. I think I'm a little bit fast, but.
Aisha, Prof. Adri, are you still there?
Ready?
Okay.
Okay, thank you, Dr. Aisha. Presentation good, interesting. And any question from Inna Ibdu? Hello, Doc. I'm Inna Ibdu. I'll ask you about according your study. Is our method can be used for oral cancer in the future, not only for SCC? Thank you.
Of course, this is the ideal way how you should do it in either in cancer or not in cancer. This is this protocol is the main that is supported by the definition group of biomarker. Yeah.
Okay. And the second answer from Puji Handayani. Assalamualaikum, Doc. Can we have the PDF or you publication? Thank you.
Yes, of course. Yes, I can send it to the committee, and they can give it to anyone.
Thank you very much, Dr. Aisha. And any question? Oh, 1, 2, 2. The answer, Amy from Ami in India, Sharaveli. Thank you, Doc. According to your study, when is the right time we deadlock even talk they are asymptomatic. Thank you. Please, Dr. Aisha.
Yeah, I am just reading this the question on the screen in order to understand what is the meaning. Even though you are asymptomatic. Indeed, we cannot determine by ourselves what is the right time that we can detect the cancer. I mean, if the patient can notice some changes and go earlier to the oncologist or to the oral medicine or to whatever, and it help. I mean, it can show those people what he or she noticed. This will be a perfect time, but there is no, I mean, a right time. But what the biomarker can help, a biomarker can help us in case we have either we have a suspicious lesion, or we can use a biomarker can help in such a case. But in case if there is no any symptom and there is no any changes, in case we have what is called screening biomarker, you can expose the patient to screening biomarker. I mean, there is nothing with the time, nothing. No, we cannot control the time when the patient come and which no.
Okay. Thank you, Dr. Aisha. Any question, please? Oh, no question. Thank you for Dr. Aisha. Your presentation very good. And we will end the first session before the handover of the certificate. Dr. Israyani.
Yes, Prof. Okay, Dr. Aisha, this is your e-certificate, and it will be sent in your email. Thank you very much for the presentation.
Thank you so much for having me. Thank you.
Thank you, Dr. Aisha.
Thank you, Dr. Aisha. Bye-bye.
Bye.
Okay. Dr. Marhamah? Sudah
Oke.
Ya. Tunggu dok, saya dulu perkenalkan Ki. Then we add the second presentation. Dengan peraturan yang sama, the same rules. Presentation time is 45 minutes. Question and answer time 15 minutes. Oke, sebelumnya saya akan memperkenalkan atau akan membacakan riwayat hidup dari Dr. Marhamah. Name Dr. Gigi Marhamah M.Kes. Head Lecturer, Functional Position. Place and date born in Sopeng, March 5, 1963. Kemudian beliau adalah lecturer of the Faculty of Dentistry Universitas Hasanuddin. Kemudian beralamat di Jalan Perintis Kemerdekaan kilometer 10 Universitas Hasanuddin Kampus Makassar. Kemudian riwayat education-nya atau education history S1 di Fakultas Kedokteran Gigi Universitas Hasanuddin. Kemudian S2 beliau di Fakultas Kedokteran Gigi Universitas Airlangga. Kemudian untuk Doctor of Medicine S3-nya beliau di Fakultas Kedokteran Universitas Hasanuddin pada bidang kedokteran gigi anak. Dan beberapa beliau mempunyai banyak kegiatan pengabdian. Di antaranya adalah perawatan gigi secara gratis pada se-Makassar. Dan banyak lagi penelitian-penelitian beliau yang sudah tidak bisa kami bacakan satu persatu. Dan Dr. Marhamah adalah salah satu dosen yang banyak sekali mempunyai kegiatan-kegiatan, terutama kegiatan-kegiatan pengabdian dan juga publikasi. Next, untuk mempersingkat waktu, in order to shorten the time, we invite Dr. Gigi Marhamah present his paper and tip. Judul presentasinya adalah Bad Habit in Children and Their Impact in Oral Health and Development Teeth. Silakan, Dok.
Terima kasih Prof. Ajri. Alhamdulillah diberi kesempatan pada hari ini. Baiklah, saya akan membawakan materi saya pada hari ini. The honorable all speakers and participants in the fourth International Conference on Biophysical Technology in Dentistry. Assalamualaikum warahmatullahi wabarakatuh. I am Dr. Gigi Marhamah M.Kes from Faculty of Dentistry, Hasanuddin University. I would like to also give a warm welcome to our sister from Yemen, Miss Aisha Al-Hussein, Al-Jamaei. I also have Arabic blood from Hadramaut, Yemen. My father's grandfather was Salim Al-Bakir. So I hope Miss Aisha, sometimes you will be like to go to Indonesian country, my country. Even though we are middle of pandemic and we cannot meet in person, but today I'm very glad to see you or virtually, and I'm so excited to present my my research paper about bad habits in children and their impact in oral health and development of teeth. Bad habits are extrinsic factor that can affect tissue like teeth, alveolar bone, tooth supporting tissue like gums, periodontal ligament, and other oral mucus like tongue, lip, cheek, palate, edge. Bad habit affect dentofacial functions such as the process of chewing, speaking, tooth occlusion, and the structure of the tooth supporting tissue, as well as aesthetic during the teaching period. A habit is a repetitive action that is performed. Habits are certain actions carried out repeatedly, while oral habits are habits leading to development of abnormal form. A habit is a repetitive action that is performed automatically or spontaneously. This behavior generally occurs of childhood and is mostly resolved spontaneously. A habit in the oral cavity that can cause malocclusion is called a bad habit. Bad habit affect dentofacial functions such as the process of chewing, speaking, tooth occlusion, and the structure of tooth, supporting tissue, and aesthetic. Bad habit is defined as a stereotypical repetition of the functions of the mastication system, which differ qualitatively and quantitatively from the psychological function. Bad habit usually happen quietly, so that children do not realize that they often do this. The habit is initially carried out is a conscious stage, but repetition result is decreased awareness and motor response. Eventually, the habit is fully formed and becomes part of the mind routine, making it more difficult to get rid of. Bad habit can be divided into two main groups: acquired oral habit and compulsive oral habit. And child compulsive oral habit. Acquired oral habits is a learned behavior can that be stopped easily as the child grows older, but the child can break the behavior and start with over habit. Compulsive oral habit is a behavior in children that is hard to lose. But if the child continue to be pressured into stopping the bad habit, it will make the child anxious and worried. So etiology, bad habit is satisfaction not met in the oral pass, page, 2, premature weaning, 3, anatomical from abnormality, 4, disease, 5, non-harmonious relationship between child and parents, and 6, emotional disorders. Oral habits are a habit that lasts at least 6 hours a day. If the frequency is high enough with sufficient intensity, it can cause malocclusion because the teeth are an integral part of the surrounding structure, such as chewing muscle tissue, jawbone, and face, which have a close and reciprocal relationship. So, growth and development disorder in the structure can affect the arrangement of teeth and face versa. Habit in the oral cavity can affect head tissue like teeth, alveolar bone, and supporting tissue like gums, periodontal ligament, and other oral mucous like tongue, lips, and palate. Oral habits are normal in children aged less than 6 years and can stop under hour in children aged less than 6 years. If the oral habit, bad habit persists after the age of 6 years, they can cause abnormality in the dentofacial structure, such as malocclusion, facial deformity, and deformity of the plates. Oral habit that still persists in children over 6 years of age can be caused by an abnormality in bodily function and psychological disorders due to emotional stress and acute as the result of psychological stress. Bad habits are common in children with normal psychology. psychological status, but can also occur in children with development problems, emotional difficulties, or psychological disorders. Bad oral habits are often distributed as a cause of risk factor for a various types of malocclusion. But in on open bite, be it on open bite with the maxillary incisor tips, especially the mandibular incisors and the mandibular incisors, lingually, and the eruption of some of the incisors of obstructed casing, causing increase overjack and decrease overbite. There is also increased prevalence of posterior crossbite with the use pacifier. In dentistry, the irregular adjustment of the teeth and the abnormal relationship between the upper and lower jaw is called a malocclusion. Malocclusion is the irregular or abnormal relationship between the teeth when the upper and lower jaw occlude. Malocclusion is a form of relationship between the upper and lower jaws and the deviates from the standards. The standard form in which is considered normal. Normal malocclusion can be caused by an dental-facial imbalance. Malocclusion is a fairly large dental and oral health problems in Indonesia, and its prevalence is still very high, around 80% of the population, and in the third place, other dental caries and periodontal disease. The prevalence of malocclusion in Indonesia is still high, so around 80, about 80%. The prevalence of thumb sucking in children ranges from 13, 45%, about 80% of baby suck their thumbs until around 18 months of age. But this habit is still found in preschoolers, even up to 6 years of age. Oral habit are extrinsic factors such as nail biting, objects such as pencil and pens, sucking of fingers, sucking of cheek, and breathing through the mouth. Oral breathing in the habit that most often cause abnormality in the facial structure and occlusion of the teeth. The habit of breathing through the mouth of a breathing disorder. Breathing is one of the vital function mechanism in the human body, which is carried out by inhaling oxygen through the nose. But the mouth, which can also be used as the way in and out of air, is used as a substitute for the function of the nose by children who have the habit of breathing through the mouth. So the etiology of malocclusion can be classified into general factor and local factor. General factor are those that have no direct effect on teeth. Local factors are that have a direct effect of teeth. Bad habit are one of the common factors that play a role in malocclusion. So bad habit are one of the common factors that play a role in malocclusion. Bad habit include sucking finger and thumbs, passing tongue, biting lips and nail, incorrect swallowing, mouth breathing, and bruxisms. And oral habits are extrinsic factors such as nail biting with objects such as pencil and pen, sucking of fingers, sucking on cheek, cause abnormality in the facial structure and occlusion the teeth. And etiology factor for nail biting itu psychological disorder and treatment by physical psychological approach. Bruxism is a chronic habit of clenching the jaw. Bruxism is a chronic habit of clenching the jaw and grinding the teeth that occur in children, especially children under 5 years, especially children under especially children under 5 years. Bruxism are etiological factors. For example, premature contact between the upper and lower teeth or incomplete tooth restoration. And systemic factor, for example, allergy or malnutrition. Psychological factor, for example, psychological disorders or increasing emotional. And treatment for bruxism, for local factor can be treated with conservative dentistry treatment, tooth occlusion adjustment, psychological factor can be treated with psychological approach. Next. Material and methods. Other bad habits that affect babies and children include sleeping on one side of the face or sleeping of the below. This habit in infant or children who are experiencing active growth can cause facial asymmetry. Discussion. Yes. Next. Oral habits are habits that can cause change in occlusal relationship. One of the literature that looks at the relationship of bad habit to the incidence of malocclusion children entailed the description of bad habit and the incidence of malocclusion in students of SD Negeri 19 Pemecutan conducted by Susanto F. FKD et al. Sought a relationship between bad habit, the oral cavity, and the incidence of malocclusion. Both of the studies found that the most of the children with bad habits did thumb or finger sucking. Of the 5 journals synthesized 80% of the bad habits are often carried out by children that impact the oral health in terms of finger sucking. Research conducted by Feroza A.N. et al. And Muhammad SDS et al. One of the oral habits such as mouth breathing can increase the prevalence of malocclusion. The result of Feroza, severe malocclusion occurred in the growth with the habit of the breathing thought the mouth many thrust low at the stem, sucking premature loss and type of malocclusion. All bad habits have the same effect on malocclusion. Salmi, mana Salmi? Study by Samad R et al. And Haider et al. Saw a significant relationship between anterior tongue thrust swallow, ATTS, thumb sucking, premature loss of the teeth, and the malocclusion. All the bad habits have the same effect on malocclusion. Impact of malocclusion, aesthetic disorders, phonetic disorders, and mastication disorders. One of the causes of the malocclusion is the premature loss of primary teeth. Research on malocclusion and the premature loss of primary teeth conducted by Salum et al. In Baghdad in children of age 3 to 9 years showed that premature canine lost only cause class 1 malocclusion. Iya. Lanjut, Mas. Based on the analysis of several literature related to bad habit in children that affect dental health and dental growth in children, several conclusions are obtained that are in accordance with the problems formulation in this literature review. The overview of bad habit in children that impact the tooth and mouth health and thumb sucking habit that can cause malocclusion in children. Malocclusion is formed due to the interaction of various factors, like internal and external. The types of bad habit in children that affect the tooth growth are thumb or finger sucking, interesting foreign object like pencil biting, pen and nail biting, tongue thrusting, mouth breathing and lip sucking or lip biting. Thank you very much. Thank you, Prof. Ajri and Dr. Isra.
Thank you, Doc. Prof. Ajri, your audio is mute. Please unmute.
I'm sorry. Oh yeah. Thank you, Dr. Marhamah. A good presentation. And any question from column Q&A? No open quiz, no question. Mungkin ada beberapa pertanyaan mungkin yang sambil menunggu pertanyaan dari peserta. Mungkin
silakan Ki Dok.
Ya,
Silakan,
sambil menunggu pertanyaan, mungkin bisa sedikit Dr. Marhamah menjelaskan karena dari beberapa bad habit yang sudah dijelaskan tadi, seperti bruxism, kemudian mengisap jempol, dan beberapa bad habit lainnya, itu penanganannya kebanyakan dilakukan dengan terapi psikologis. Mungkin bisa dijelaskan terapi psikologisnya itu apakah harus dikonsul ke psikolog ataukah ada beberapa penanganan fisiologis yang bisa dilakukan oleh dokter anak?
Iya, jadi begini Prof, pada umumnya bad habit ini dianggap itu persisten kalau itu dan perlu penanganan khusus ketika anak-anak itu melakukannya di atas 6 tahun. Kalau di bawah masih berumur di bawah 6 tahun, itu biasanya masih kita lakukan pendekatan secara persuasif kepada anak-anak kita dan bahkan ada yang berhenti dengan sendirinya. Ya seperti tadi dikatakan bahwa ada beberapa faktor, extrinsic faktor dan intrinsic faktor. Jadi kita lihat faktor-faktor apa yang menyebabkan terjadinya bad habit itu. Kalau penyebabnya intrinsic faktor seperti tambalan yang ketinggian sehingga dia selalu menggertakkan giginya, itu bisa dilakukan di klinik dokter gigi, diperbaiki dengan occlusal adjustment misalnya. Tapi kalau dia faktornya misalnya karena faktor dari orang tua, ada faktor eksternal misalnya dari lingkungan yang membuat dia merasa nyaman dengan kebiasaannya karena dia kurang diperhatikan atau kurang mendapatkan apresiasi dari lingkungan atau khususnya orang tuanya, maka itu pendekatannya memang perlu secara khusus. Katakan misalnya dia harus dikonsul ke psikolog atau ini, dan tentu saja orang tuanya pun juga perlu diberi pendekatan khusus kepada orang tua anak ini. Jadi dilakukan secara holistik. anaknya diterapi, orang tuanya pun juga diterapi dengan pendekatan personal, ya, persuasif terutama. Ada juga kebiasaan mengisap jempol pada anak-anak yang masih berumur 2 tahun. Itu otomatis biasanya itu sembuh dengan sendirinya dan tidak perlu diterapi. Yang biasanya perlu diterapi itu ketika kebiasaan ini di atas 6 tahun dan itu pun juga setelah kita perhatikan bahwa ini persisten. Karena ada yang di atas 6 tahun namun bisa dengan gampang dihilangkan. Seperti misalnya menggigit pensil atau menggigit barang-barang atau kuku. Kalau mereka didekati dengan, terutama kalau mereka sudah mendekati usia-usia hampir puber, umur-umur 9-10 tahun, itu biasanya gampang diterapi dengan mengatakan bahwa jangan seperti itu, nanti kamu jelek, nanti kamu ini tidak cantik lagi. Itu mereka biasanya berhasil terapi seperti itu. Jadi pada umumnya memang kebiasaan buruk ini kalau dia sifatnya eksternal, faktor penyebabnya pada umumnya itu bisa diterapi dengan psikologi. Saya kira itu, Prof.
Ya, terima kasih Dr. Marhamah.
Iya.
Please column Q&A. First question. Great presentation, Doc. I want to ask you, among the bad habits, which bad habit can you suffer malocclusion in children? Thank you, Dok. Pertanyaan ini dari Dr. Ardo Sabir. Silakan, Dr. Marhamah.
Bisa diulang pertanyaannya, Prof? Tadi.
Oh, ya.
Berapa lama? How long?
Pertanyaan Dr. Ardo Sabir. I want to ask you, among the bad habits, which bad habits can cause several malocclusion in children?
Oh ya. Jadi yang paling biasanya yang paling banyak menyebabkan malocclusi itu biasanya kebiasaan buruk mengisap jempol. Itu mengisap jempol. Jadi itu yang biasa menyebabkan malocclusi dibanding dengan kebiasaan-kebiasaan yang lain. Jadi yang bisa menyebabkan malocclusi yang berat itu yang mengisap jempol. Dan repotnya lagi biasanya anak-anak itu sulit kita tangani karena kebiasaannya itu membuat dia di memorinya itu menyebabkan dia itu rasa nyaman, ya. Kadang-kadang tangannya itu diberi merica atau dikasih kasa, dililitkan kasa agar kalau dia mengisap jempolnya dan dipasang pada waktu dia tidur. Jadi bukan pada waktu dia terjaga, dipasang pada waktu dia tidur itu, Dok. Ada juga orang yang menggunakan larutan yang pekat tetapi tidak membahayakan anak. Tetapi yang banyak dipakai itu biasa larutan merica. Jadi anak 1-2 kali mungkin ini lama-kelamaan dia tidak akan mengisap lagi. Jadi yang paling banyak melakukan severe malocclusion itu adalah saking. Itu Dr. Ardo, Prof. Ardo.
Iya. Baik, terima kasih Dr. Marhamah. Kami lihat di kolom Q&A ini sudah tidak ada pertanyaan.
Yeah.
Kemudian kalau kita lihat waktu ini masih tersisa 12 menit. Mungkin oh ya, maaf Dok, ini ada pertanyaan selanjutnya.
Iya.
Di kolom Q&A dari Dr. Christine Rohani. Terima kasih Dr. Marhamah, presentasi yang sangat menarik. Saya ingin bertanya, apakah ada alat yang bisa digunakan untuk anak-anak yang bruxism? Demikian pertanyaannya, Dr. Marhamah.
Kalau alat yang dipakai untuk anak yang bruxism, saya belum pernah melihat contoh alatnya, tetapi pernah di dalam satu simposium itu diperkenalkan alat yang seperti karet begitu, ditaruh ditaruh di antara, seperti dibungkus itu gigi dengan karet dan dipasang pada waktu jam-jam tidur anak tersebut. Akan tetapi itu tidak lumrah, tidak hanya diperkenalkan begitu saja pada waktu acara simposium itu. Sedangkan untuk perawatannya yang kami kenal selama ini adalah pendekatan secara psikologi. Jadi alatnya kami belum pernah memberikan alat seperti itu pada anak yang bruxism. Pada anak-anak juga memang jarang yang bruxism, cuman ketika dia bruxism memang perlu kita tangani sebab giginya bisa emel giginya bisa terkikis dan lama-kelamaan, apalagi gigi pada anak itu masih belum compact enamelnya, jadi belum sepadat orang dewasa itu, Dokter Christine. Jadi mungkin memang perlu dipertimbangkan bagaimana penanganan secara dini anak yang bruxism seperti ini. Tapi ada kasus memang anak-anak masih pada usia anak bruxism, dan kemungkinan juga disebabkan karena anak ini mengalami tekanan atau tetapi orang tua tidak mengetahui tekanan apa yang menyebabkan, atau secara psikologi anak ini stres atau apa. Orang tua masih bertanya-tanya kadang-kadang kenapa anak saya seperti ini. Secara teori ilmuwan para penemu mengatakan bahwa itu mungkin karena anak-anak stres atau anaknya mengalami psychological disorders. Jadi alatnya kami memang belum lihat yang mana yang dipakai untuk anak yang bruxism.
Ya, Dr. Marhamah.
Iya. Biasanya kalau sudah terjadi begitu ya seperti
atau saya lanjutkan lagi pertanyaan yang selanjutnya, Dok?
Disarankan biasanya menggunakan stainless steel crown kalau anak-anak yang bruxism. Kalau ternyata enamelnya tetap terkikis, biasanya digunakan stainless steel crown. Baik.
Ya, demikian jawaban pertama untuk bruxism alat. Kemudian ada pertanyaan lagi ini, Dok, yang masuk.
Iya.
Dari Dr. Nur Hikmah.
Iya.
Presentasinya sangat menarik, Dok. Tapi saya tanyakan, apakah ada manifestasi oral pada pasien bruxism pada anak? Jadi manifestasi ke oral. Itu pertanyaan dari Dr. Nur Hikmah. Silakan, Dok.
Manifestasi oralnya jelas enamel giginya itu terkikis, Dok. Kalau biasanya bruxism yang parah, yang severe ya, itu biasanya gigi yang mengalami bruxism setiap hari itu biasanya mengalami pengikisan pada daerah pusal dari gigi geraham anak tersebut. Untuk itu biasanya diterapi dengan crown. Kalau sambil bertumbuh kembang rahangnya anak itu biasanya kita terapi dengan stainless steel crown atau porcelain. Yang jelas enamelnya pasti terkikis pada area yang mengalami atau terjadi bruxism. Itu manifestasi oralnya. Kalau pada jaringan lunak tidak ditemukan apa-apa, hanya pada enamel giginya.
Masih ada lanjut pertanyaannya, Dok? Jawabannya masih dilanjut? Baik, kami lihat di kolom QA, pertanyaan sudah tidak ada, dan waktu ini masih tersisa 7 menit. Mungkin pertanyaan lagi kalau misalnya ada yang masuk. Ya, sepertinya sudah tidak ada. Iya. Untuk Dr. Kristi dan Dr. Nur Hikmah, mungkin sedikit penjelasan bahwa untuk untuk bruxism itu biasanya sudah dijelaskan tadi oleh Dr. Marhamah dengan begitu jelas. Dan biasanya kalau anak-anak itu dilakukan perawatan, itu biasanya kita menggunakan stainless steel crown. Tetapi tentunya biasanya harus dilakukan dulu terapi awal untuk menghilangkan bruxismnya. Ya, demikian barangkali hadirin sekalian peserta seminar. Presentasi yang cukup menarik dari Dr. Marhamah. Mungkin kalau jika tidak ada pertanyaan lagi, saya lihat sudah tidak ada. Kita bisa mengakhiri presentasinya dan sebelumnya akan diberikan sertifikat dari panitia. Silakan Dokter. Sertifikatnya akan di-email ke Dr. Marhamah.
Iya, Prof.
Terima kasih banyak Dr. Marhamah atas presentasi yang menarik dan begitu banyak pertanyaan.
Terima kasih banyak Prof. Fajri.
Dan sudah dijawab dengan sangat jelas. Barangkali demikian untuk presentasi kedua presenter. Saya kembalikan ke Dr. Israyani sebagai MC. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Prof. Fajri, and thank you, Dr. Marhamah, for the nice presentation and the explanation about the presentation today. Okay, this is the last of the 8th session of this event. So, ladies and gentlemen, distinguished participants, today we're gonna going to the next session. Is 9th session of this event that will be led by Prof. Sri. But before we enter to the next session, please, we're going to show you our video of the sponsor. Okay, please check it out.
Okay.
Sensodyne Repair and Protect is a daily toothpaste for the treatment and prevention of dentine hypersensitivity. Sensodyne Repair and Protect contains Novamin, an advanced calcium and phosphate bioglass technology. A single Novamin particle ranges from about 5 to 20 micrometers in size. New Sensodyne Repair and Protect also contains sodium fluoride. The unique formulation has been developed so that both the Novamin particles and sodium fluoride are protected in their active form and available when brushed with in the mouth. When Novamin comes into contact with saliva, it releases calcium and phosphate ions to build a hydroxyapatite-like layer over and within the dentine tubules. This begins with an ionic exchange between sodium in the Novamin and hydrogen ions from the saliva. This ionic exchange causes a small localized rise in pH that promotes formation of hydroxyapatite. Novamin particles can bind to collagen fibers in dentine. Once deposited, these particles continue to react and act as a calcium and phosphate reservoir to build a hydroxyapatite-like layer over dentine and within the dentine tubules that also incorporates fluoride. This hydroxyapatite-like layer is chemically and structurally similar to biological apatite, forming the inorganic portion of dentine. The reparative layer formed by Sensodyne Repair and Protect starts to form after the first brushing and promotes the dynamic mineralization of dentine to build a substantive reparative layer over the dentine and within the tubules, which in turn reduces dentine permeability. Decreased permeability can relieve dentine hypersensitivity by decreasing the fluid flow within tubules, thereby reducing the activity of nerve endings. Sensodyne Repair and Protect delivers clinically proven relief from the pain of dentine hypersensitivity with twice daily with Repair and Protect.
Okay, ladies and gentlemen, distinguished participants, now we are enter in the 9th session as the last session for this event. That will be led by the chairman, Professor Dr. Gigi Oktawati, Sp.Perio consultant. So, before I introduce her, remembering you for if you have any questions, please type and insert in Q&A box below. Okay, brief introduction of the chairman, Professor Dr. Gigi Oktawati, Sp.Perio consultant. Oh, okay. Today, the chairman before Prof. Sri will take over by Dr. Abul. Dr. Abul, are you there? Oh, okay. But the 9th session, it's gonna be presenting on the 13 o'clock today, 1 p.m. Makassar time. So, ladies and gentlemen, distinguished participants, we're going to break session and see you again in 1 p.m. In Makassar time, and bye-bye. Assalamualaikum warahmatullahi wabarakatuh. Good day, Dr. Peter. How are you there? No, I can't hear you. Please unmute.
Sorry. It's a very nice afternoon here. Is that okay?
How about COVID in Australia, Doc?
COVID?
Yes.
In my state, it's not too bad. We've got very few cases, only half a dozen. But in other states, it's very bad.
Oh.
There's hundreds of people dead. Not quite thousands, but hundreds dead in Melbourne. And Sydney's very bad.
Oh. So
it's not good.
How's about the traffic into Australia or out from Australia? From Sydney, maybe.
So we're at the moment, our government won't let us leave Australia. We have to stay in the country.
Oh, okay.
So we're actually, and we're not allowed to travel from one state to another. So it's
still work from home.
But I'm quite lucky. It's not too bad in my state.
Okay. So when if the COVID or pandemic is gone, we hope you can going to Makassar.
Yes. So
have you here before?
Yes, I came in February.
Oh yeah, in
for the conference. Yeah.
Yeah. Oh, okay.
I remember it well. You were very kind to me.
Thank you. Hope you can be here next time.
I would love to come again.
Okay.
Hopefully you'll still want me to come after today's talk.
I mean.
I take it I can run it from the screen here. I can share screen.
Yes.
Yeah,
please.
That's fine. So I'm an hour and a half ahead of you. So it's now just coming up to 2:30.
Okay.
Has that got it?
Yes, it's work.
Yeah, brilliant. So if I...
But on a slideshow.
No, if I put it onto the main screen like that.
Okay. Yeah.
Does that give you the full, that just gives you the pictures, does it?
Okay. It's nice.
That's okay, is it?
Yeah. Nice and clear.
Okay, well, I've tried very hard. I've had quite a few Zoom meetings in recent months. So try to keep it easy to read.
Okay.
So you've all been very busy.
Yeah.
Last afternoon.
Yes?
It's your last afternoon. All finishes tonight.
Work from home is busier than office.
Yes. Unfortunately, I've not had to work from home because I've had to be in the hospital all the time.
Oh yeah.
Yeah. So I was in the hospital this morning.
Oh.
So because of COVID, we've had patients that would normally go to Melbourne and Sydney come to us because we've got less COVID. So we've been busier.
It must be reduced in your patient count.
Yeah, it keeps us busy. And with people in lockdown at home, there's been many more accidents. Many more children coming off bikes, breaking teeth, breaking mandibles and things. So we've been very much busier in the last 3 or 4 months since COVID struck.
Okay. Do you have some surgery today?
Not today. I had surgery yesterday.
Oh.
I had outpatients to see today. So patients that will be operated on next week, saw them this morning.
Oh, you're so busy.
So it is quite busy. So I work with my neurosurgery colleagues. So I have a meeting with them on a Saturday morning.
Okay. Then next, continue in.
Yeah.
How many times you go to Indonesia? Dr.
To Indonesia, probably about a dozen. I've been to Bali 6 or 7 times and gone to the hospital in Denpasar. I've also been to Samarang and I've been to Jakarta, been to the Craniofacial Center in Jakarta. So yeah, maybe about a dozen. So a few times, more than a few times. So I like Indonesia. It's
Have you ever go to Toraja in south of Sulawesi?
Yeah.
Toraja.
Yeah. So my trip to Makassar in February was the first time I've been to anywhere outside Java.
Oh, but you don't. You have not been in Toraja.
No.
Oh, there's so
much to learn.
Maybe next time.
Maybe next time. Yeah.
When COVID is gone.
Yeah. When our governments lets us leave lets us leave Australia.
Yes.
Yeah. Hopefully next year.
I mean. Okay, it's 1 p.m. Makassar time right now. So we're going to begin the session, maybe.
Do you want me just to start, or does the chairman want to say something?
Yeah. Okay, I just want to say, please stop share your screen. Okay, thank you, Dr. Peter. We're going to start this last session in this event. It's going to lead by Dr. Abul. Dr. Abul, are you there?
Yes, very clearly.
Okay, please open your video maybe. Oh, okay, thank you. Sorry, I can't see it before. Okay, ladies and gentlemen, distinguished participants, we are now entered the last session of the 4th International Conference on Biophysical Technology in Dentistry. And this session will be led by the chairman, Dr. Gigi Abul Fauzi, Sp.BM consultant. But before I introduce him, please, we want to show you some videos from the sponsor. Please check it out.
Sensodyne Repair and Protect is a daily toothpaste for the treatment and prevention of dentine hypersensitivity. Sensodyne Repair and Protect contains Novamin, an advanced calcium and phosphate bioglass technology. A single Novamin particle ranges from about 5 to 20 micrometers in size. New Sensodyne Repair and Protect also contains sodium fluoride. The unique formulation has been developed so that both the Novamin particles and sodium fluoride are protected in their active form and available when brushed with in the mouth. When Novamin comes into contact with saliva, it releases calcium and phosphate ions to build a hydroxyapatite-like layer over and within the dentine tubules. This begins with an ionic exchange between sodium in the Novamin and hydrogen ions from the saliva. This ionic exchange causes a small localized rise in pH that promotes formation of hydroxyapatite. Novamin particles can bind to collagen fibers in dentine. Once deposited, these particles continue to react and act as a calcium and phosphate reservoir to build a hydroxyapatite-like layer over dentine and within the dentine tubules that also incorporates fluoride. This hydroxyapatite-like layer is chemically and structurally similar to biological apatite, forming the inorganic portion of dentine. Reparative layer formed by Sensodyne Repair and Protect starts to form after the first brushing and promotes the dynamic mineralization of dentine to build a substantive reparative layer over the dentine and within the tubules, which in turn reduces dentine permeability. Decreased permeability can relieve dentine hypersensitivity by decreasing the fluid flow within tubules, thereby reducing the activity of nerve endings. Sensodyne Repair and Protect delivers clinically proven relief from the pain of dentine hypersensitivity with twice daily with Repair and Protect.
Okay, thank you for the videos. The 9th session of the 4th International Conference on Biophysical Technology in Dentistry is supported by GSK. Okay, ladies and gentlemen, distinguished participants, before I introduce our chairman today, I'm reminding you for if you have any questions, please type and insert the question in Q&A box below. Okay, now I'm going to introduce our chairman, Dr. Gigi Abul Fauzi, Sp.BM consultant. And he was born in Ujung Pandang, south of Sulawesi, Indonesia, in June 6 in 1979. He was graduate his dentist degree from Hasanuddin University, specialist of oral and maxillofacial surgery from Pajajaran University, and he is currently a lecturing staff at Oral and Maxillofacial Surgery Department of Faculty of Dentistry, Hasanuddin University. He has a lot of research and publication, and the newest one of his publication with title is Demography of Oral Health Status for Students and Teachers in Islamic Boarding School in 2019. So, Dr. Abul, please, the floor is yours.
Thank you, Dr. Isra. Assalamualaikum warahmatullahi wabarakatuh, and good day, all ladies and gentlemen. As we know, this is the last session on 4th International Conference on Biophysical Technology in Dentistry. Right now, we have our speakers, Mr. Peter John Anderson. Mr. Peter John Anderson is a consultant craniomaxillofacial surgeon, and also he have a higher training for plastic and reconstructive surgery in Australia. He have a dual nationality, British and Australian, of course. From the CV, I see he have a lot of clinical teaching, training, award, and research, about 53 pages. Maybe I can't read all, but Mr. Peter, maybe we have 45 minutes for presentation and 15 minutes for question and answer. Maybe right now you can do your presentations. Time is yours, Mr. Peter.
Okay, thank you very much indeed. That's very kind for your introduction. I'd like to start off by thanking all the members of the organizing committee for asking me to come and talk to you this afternoon. And I hope that I can show just some of the applications and some of the insights that have been involved in using nanotechnology in a particular aspect of dentistry. So what I really wanted to start with, I can just make sure I've got the right screen. There we go. Is we know that in our clinical practice as surgeons and as oral surgeons that we have a whole variety. We come across clinical problems every day, and there are many problems in dentistry that we would love to be able to have problems to improve the lives of our patients. We are aware, as nanotechnology has been available in the last few years, that its potential to be used and to be applied within the dental field is actually something we've become aware of, but it's very difficult to know exactly how we can actually use it. And it takes a little bit of lateral thinking to try and work out, well, how can we use it and translate all these potential scientific advancements into clinical practice. So today what I'm going to talk about is something that's very relevant to all of us in the dental field, not just oral surgeons, but all of us who are involved in the development of the child's head. And of course, in growth and development, the sutures, both the cranial sutures and the facial sutures, are really important sites of facial growth. So you know they can occur both in the skull, as we can see in the on the picture here on your right-hand side. We know that in the skull we've got both the soft spots, the fontanelles.
I interrupting you.
Yeah.
Do you have share your screen?
Have you got? Okay, I do beg your pardon. Hang on.
Yeah.
Have you got it?
Not yet.
Is it? Have you got the pictures now?
Not yet.
Not yet. Okay, hang on. Hang on, I might need to leave the talk temporarily and let's get back into share screen. Sorry about that.
Never mind.
It's okay.
Yes, yeah. The wonders of technology.
Okay.
Have you got my screen?
Clear, yes.
Now what I'll do is I'll just convert that onto full screen for you. Is that okay?
Yes.
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 We've got a nice. There should be a nice a picture with a child's skull on the front of it. Is that okay? Yeah. Okay. Chairman, you're nodding, so I'm okay. Good to go. Okay. What I was going to talk about is to apply something that's really important to all of us as dental practitioners, and that of course is growth of the facial and my own particular interest, the craniofacial skeleton. And you'll be aware that within the skull, we've got both the growth plates of the skull and the soft spots, the fontanelles, all of which are really important to maintaining the growth of the upper third of the face. But it's not limited just to the skull, which is my own particular surgical interest, but it's also really important, particularly in the middle third of the face, and particularly in relation to the maxilla. And this is of particular importance to our orthodontic colleagues. And this suture in particular, the mid-palatal suture, is particularly important. We know that in life, this fuses usually in early teenage years, but as you'll see from the right-hand side of my picture, it's used very extensively in orthodontic practice for rapid maxillary expansion, both at different stages in childhood. And if we could alter the way in which those sutures behave, make them more pliable and try and prevent them fusing, then this not only has implications for me as a cranial surgeon, but also has very significant applications in everyday orthodontic practice. So although suture biology may not be one of the most interesting topics or well-taught topics at dental school, it actually has enormous implications, particularly in the field of orthodontics and in studying facial growth. So that's why we need to study sutures and why understanding suture biology is important for us in the dental field, not just in the medical field. So what are these sutures all made of? And this is a diagrammatic representation which shows that sutures are highly complex, heterogeneous cellular organizations. In between the two bone plates, we have both periosteal cells around the bone, but in between the two bone plates, there's a set of cells in the middle there which, if they're not true stem cells, and we can do various tests to look for markers of how well differentiated they are, they're certainly pluripotential cells. The role of these cells in normal biology is for them just to turn over and to reproduce very slowly in the middle. And as they move towards the bone edges, these cells start to undergo differentiation under appropriate stimulation and of the appropriate growth factors. That can be down the osteogenic route to form pre-osteoblasts, then osteoblasts, and then start actually becoming mature osteoblasts and actually start producing bone. So it's a very complex, highly regulated biological system, tissue system. But we know that the regulation of it is controlled by a whole host of different growth factors, which may be released locally or systemically, which can impact on it. And it's those particular growth factors which potentially we can manipulate and use to try and alter the way in which the sutures behave. And in our case of our orthodontic colleagues, it's can we stop the production of pre-osteoblasts and osteoblasts to keep it more fibrous so that it's much easier to undertake rapid maxillary expansion. And for those of you that are oral surgeons, you'll know that in later in teens, we usually actually have to do an osteotomy to actually put a chisel or osteotomize along that maxillary suture if we wish to get some widening of the maxilla. So this generalized structure of the suture is the same in all different parts of the facial skeleton and in the cranium as well. So for me as a cranial surgeon, the problems that arise when sutures don't behave properly can have two effects. It can either be like the picture on the left-hand side, which shows that if just one growth plate is abnormal, then you've got compensation overgrowth from the adjacent growth plates, and you get a well-recognized bizarre head shape which may occur and may have both functional but certainly has aesthetic problems for an affected child. More importantly, but rarer, is there are some forms syndromic disease which is controlled by genes and gives a syndromic craniosynostosis, where not only are the growth plates, the sutures in the skull affected, but also the growth plates and sutures within the face. And if we have a look at the child on the left-hand side who's got Crouzon syndrome, one of the more common of the craniosynostosis syndromes, and we can see that in addition to his head, we can see that his eyes are very prominent. The reason being that the sutures and growth plates around his orbit have closed together too early, and the orbit hasn't got sufficient growth to accommodate his eye, and therefore the eye bulges out. Can also see that the whole of the middle of his face is stenosed. He's got a very short nose that's all very constricted, and has got will have very little in the way of a mid-face airway. So what we can see is that where genes alter suture biology, they can have enormously profound effects, not just on the cranium, but on the face itself. And this obviously impacts both on the orbits in the maxilla will also affect on the jaw shape and structure, which will also impact on the position of the teeth and dental malocclusion. So often it leads to a mismatch between the maxilla and the mandible. So they're all tending to have class 3 skeletal relationships. With Crouzon syndrome, which is one of the more common of the syndromic craniosynostosis conditions, we know what the underlying factor is, and it's a whole series of mutations of a gene called FGFR2, fibroblastic growth factor receptor 2. And we can see the very profound effects that what just a single gene mutation that alters one protein, a receptor which normally sits on the outside of the cells everywhere in the body, but particularly important in the suture cells, that when it's altered can have this huge impact on local biology. So what's our clinical problem? Our clinical problem is this kind of scenario where we've got a newborn baby like we have here on the left-hand side. It's newly born. He's got the same condition as his mother's got. He's got Crouzon syndrome. And looking at him, he looks a nice, sweet little baby. But I know that as a surgeon, that it is almost certain that that baby will require multiple operations, both to make the skull bigger, to accommodate the rapidly growing brain, and will almost certainly need jaw surgery to make the maxilla, bring it forward, to improve the airway, and to correct malocclusion later in life. So the question is at this very early stage, when we look at this little baby and we look at the 3D CT scan that's been taken that shows that the growth plates, some of them are still open. We can see at the bottom there that where the blue arrow is pointed, that the sagittal suture, the midline one, is already fused. But in his case, the coronal sutures are still open. So the question is could we do something to alter the effect of the underlying gene mutation and the altered cell receptor? Can we alter the cell biochemistry so that the sutures don't actually close? And to do that, we know that we're going to need the proteins that are involved in regulating cell biology. So after a variety of studies, and I don't wish to get involved over many years, we know that we've now been able to identify some specific proteins which are very important in cell regulation, which counteract the impact of these underlying gene mutations. These have been done very briefly through a multitude of microarray studies where we've compared both the gene expression in fused sutures and unfused sutures, and looked for, using the heat map that you can see on the right-hand side, to look at difference in expression in the different sutures. And that gives us an idea of what are the proteins that are really important. Taken that further, and to provide evidence, what are the really important or clinically, what are the really significant studies, because with microarray studies, when you're studying the 38,000 genes of the human genome, you'll get many hundreds of genes that are abnormally expressed. And to try and target that down to very specific issues, you need to use sort of altered genes usually use mice, as well as doing more laboratory-based studies like PCR to study gene expression, and Western blot technology to look at protein-protein interaction. What I wanted to point out to you here, we've got a mouse here who's got exactly the same gene mutation and gene change as the baby you saw in the previous slide. It's the same type 2 fibroblastic growth factor receptor mutation. And you can see it's produced a very, very abnormal looking mouse. The mouse genome is about 90% the same as human, but this is a really, really good model of human disease for us to be able to study it and to try and understand how we can manipulate different therapeutic agents to counteract the effects of the genes. So having identified our proteins, what we need to do in many of these cases, both in our Muri model of disease and thinking about translation of how do we put that back into how we deal with affected children, is we need something that can be released very slowly. We need a low dose agent. Obviously, we have to identify the correct therapeutic range, but we have to be able to deliver it in a sustained pharmacological manner, not just as a very large amount which disappears and dissipates quickly. And this is where nanotechnology comes in. And there's a whole variety of different sorts of materials that are available to us. And at the time that we undertook the studies using the genetically modified mouse as our disease model, at that time, the best available material that we could use, where we wanted to try and get protein that was released over many weeks at a sustained therapeutic level, the only agent that was available to us that met those criteria at that time was using titanium implants. We would have loved to have used a hydrogel, and I'll come back and talk about that just at the end of the talk about what our current work is working towards. So how do we go on developing an implant? And the first thing to do is to try and work out your implant design. And a lot depends on what the size of the protein is, your therapeutic protein is that you want to act. The number of different growth factors and that can be released have got a wide range of molecular weights, anything from about 10 or 12,000 Daltons up to about 160,000 Daltons. So you need to be very specific and work in conjunction with your chemical engineers as to identify very carefully about what is the active protein molecular weight that you want to be able to deliver. The advantage being that if you can deliver it locally, then there's a huge benefit in terms of reducing systemic toxicity. And as we're looking at translating this into working in newborn babies, then toxicity is, of course, a very, very important consideration if it's going to be successfully translated. So implant design. Then having designed your implant, you need to go on and work out, does the implant actually behave in the same way? One of the problems with nanotechnology is when you get to the very small levels is that toxicity studies and toxicity they behave very differently, or have a tendency that they can behave differently. And it's very important that although we know from our oral surgery practice that we leave titanium in mandibles and maxilla after we've reduced fractures over many years, usually without any long-term complications, the same may not be the case if you're using titanium at a nano level. So it's important to undertake implant studies to check that the behavior is the same as you would expect at a macro level. Also have to go on and study not just the implant material itself, but you also have to have a look at what does that do in terms of its impact on human cells. Again, does it have unexpected reactions? It's just part of the normal, important part of assessing whether a product is going to be viable or not. And then finally, getting to do the more interesting and the key part of the study, which is, can you actually use your implant to deliver the magic protein that you want in your animal model to see whether it makes a difference clinically. So looking at our implant design, we wanted to use our animal model, our mouse model, which meant that inevitably we were going to have to use very small implants in which to deliver our therapeutic protein. And you can see here on the left-hand side of the picture at the top, number A, we've got what's essentially a 3 millimeter disc of titanium. And then looking at side on, at level C, we put lots and lots of what are like little straws, which are attached to it, and these become packed with our active protein. Again, as you can see on B and D, they're not actually quite round. These are actually designed to be hexagonal, and the size and diameter of these was all very dependent on the size of the molecular weight. of the protein that we wish to use as our therapeutic agent. You can also see that these were constructed using using both an anode, which is where our titanium disc started from, and building up the straws using cathode for different lengths of time. So in essence, the first thing that you have to determine is how long do you want your straws or your tubes that are attached to your implant to be. The longer that you make them, then the longer and more sustained release of your particular protein that you can get. So there's a series of experiments that we undertook working on different lengths of tubes to see if we could get sustained protein release for a given length of tube to work out what the optimal level was. And we were, in our murine model, trying to simulate human disease, we were looking for about 3 weeks as being a suitable period of time. But there are also the impacts of the diameter. How wide do you make your tubules to try and get release of the protein? Clearly, the bigger diameter, the greater the initial concentration is, a release of protein that you get, and the more quickly it's released. So again, protein size determines the release rate, both in terms of the length of the tube and the diameter of the tube. And the little graph on the side there shows differences in release rates given different diameters that were available for use. The other thing that you can do is where you have your nanotubules is, instead of just leaving the tubules open, is to put a biological covering over the top to help slow down the release. And we did a whole series of experiments using chitosan, which is like the body of beetle, which is very slowly degraded protein. And as you can see on the left-hand side, where you've got the orange chitosan cap put over the end of the nanotubule, that slowed down release quite considerably. And you can see from the graph that's on the right-hand side of your screen, you can see that we looked at release rates of the same protein using different items, whether there was either a chitosan cap or not, and showed that when we had the chitosan, it did seem to slow it down by quite a bit. And this looked as though it was a useful agent. Problem is that chitosan we thought was biologically inert, but in some circumstances it may interact with some of the therapeutic proteins. So you have to be a bit careful in your choice as to what you might use as an agent to try and slow down protein release. So having designed our implant, we ended up with a 3 millimeter diameter implant with multiple tubes, optimal length and diameter to give us release of protein over a 3-week period. Before we could go and progress and do any further studies, the next step was to actually, having developed the implants, was to actually put them into animals to see how well they were tolerated without any therapeutic agent, just simply putting in the titanium at a nano level. So the way that we did this, the studies here, you can see we had just used ordinary wild type mice, these are C57 blacks, where having made an incision over the cranium, without doing any surgery or anything else other than a simple incision, placed the implant in the subdermal pocket and simply closed it up and waited to see over different time periods as to whether there was a reaction to the implant either in the skin or in the cranium that was underlying it. The second stage of that, working out whether it was a viable option without it having any unwanted or undesirable tissue effects, was to have a look, the second stage was to just make a hole in the parietal bone itself, to make a defect, again, without putting the implant in place, but without any therapeutic agent, to see whether it impacted on wound healing, not just in the skin, but in this time, either in the bone of the cranium, in the parietal bone in this particular case, or in the dura that covers the underlying brain. Clearly, if the titanium had any impact on the histology of the brain, then that clearly would be totally undesirable, and we would have to reject that as a potential nanotechnology solution. You can see from the slide here of one that was done at 2 weeks, shows that the underlying brain here in the slide is, again, looks completely normal. No sign of any damage. I'm also delighted that there was no sign of damage due to my surgery in creating that defect. So it showed us that both the bone and the brain and the soft tissue, the underlying skin histology, all looked within normal range. So leaving the defects a little bit longer, this is using a critical size defect. That's a defect that you would expect won't quite heal. This is one that's been left in a mouse in our animal model, not a wild type mouse this time, but in our animal model. And we can see that it's producing what we want, and we get some bone reduction, but not quite enough to complete the defect. And again, checking that this is the defect that we want to use in our animal experiment, we can see again that it's healed. Where it's not quite healed at 3 months, there's been some bone regeneration here, but again, there's no impact on the brain with the histology. So at the end of these experiments, we can come to the conclusion, are implants actually safe? So here we have our funny looking Cruzon mouse in the preoperative state. And here we are at 3 months post-op. And here we can see that in this particular case, this animal had a complication. There's some implant being extruded, which occurred in 2 of about 100 of the animals. And we thought that that was acceptable. But when we look closely at the histology, there was no sign at all that there was any underlying tissue reaction to the titanium that was implanted. And that was very reassuring. It confirmed that the titanium implants were behaving at a nano level, similar to at a micro or a macro level. So having gone through that hurdle, we could then progress and go on to the next stage of trying to do the experiment that we really wanted to do. The other thing that we did find at this level, just putting the implants in without any therapeutic agents, is that they actually became detached rather more easily than we thought. And we thought this potentially could be serious complication. Here we've got a high-powered image of where there's been some healing bone. And you can see that there's the gray area here shows lots of little nanotubules that have become incorporated into the healing bone. Reassuringly, there's no sign of inflammatory cells around there, and it's just simply becoming incorporated, which again mimics our experience at both a micro and a macro level, that the titanium just simply is inert and doesn't seem to have any impact on the way that the tissues heal. So having established then that the titanium itself seems to behave itself in an animal model, using human cells was the next stage to see, well, is this potentially going to be able to be translated into human studies? Here we've got some images which show 4 of the titanium implants, which have actually been cultured in the laboratory with some human suture cells, which we have from our human cell bank. They've been cultured, and what we can see on the sides here is that these cells are all quite viable, they're all quite healthy. So that again was very important in demonstrating to us that the cells could remain viable, that there appeared to be no adverse effect from having the implants culture in human cell culture. These particular 4 types show just titanium alone, titanium with the tubules, and titanium with some chitosan on the top. And all of them seem to show that there seemed to be no impact on human cell growth in those cultures. Finally, the last stage of implant development was actually trying to do the definitive studies where we actually wanted to have a look at, did the implants release our magic protein, in this case it's a protein called GPC3, to see whether this would impact on the way that the sutures behaved and bone regeneration behaved. In looking at the studies that we did, again, these are animals that have had defects put in the bone here. You can see here again, we've got our typical result of what healing would have occurred without any implant present or any therapeutic agent present. And here we've got a representative example of what happens when we put our implant between the mouse skin and the mouse skull, and we load it up with our therapeutic protein. You can see that although there's a bit of a divot here within the skin, we can see that there's no adverse effect on the bone. And when we come to do our 3D micro CT study here, we can see that clearly very little bone has formed. So we have been able to reduce the bone reformation by adding our protein to our titanium nano implant, and has been successful. And now this is now undergoing evaluation for seeing how we might translate this into human patients. It's currently awaiting final permission to start a phase 1 clinical trial. For those that are particularly interested, this whole use of titanium nanotubes has been written up and published in the International Journal of Nanomedicine, and I've put the reference up there for any of the audience that may be interested. Just for your attention, it is actually a free PMC article, so it's very easy to download, doesn't cost you anything. And it is the first time that we've shown that anyone can alter skull regeneration and bone healing using titanium nano implants and a therapy as a way of delivering sustained amounts of therapeutic protein. But since this time, what else? We know that there are other aspects around craniofacial development and craniofacial anomalies that potentially could be treated with using modified growth factors or particular hormones. And here we're trying to do some experiments looking at jaw growth in patients, potentially in patients who've got Pierre Robin sequence or who've got hemifacial microsomia, where there's an undergrowth develop of the mandible. And we're trying to develop agents that will promote the growth of the neural crest cells which are currently there. And this is just showing injection using tiny amounts, which are very difficult to do at this level in such a tiny animal. We can see here a mandibular condyle, which shows that our agents are actually going to where they want to be. But in terms of trying to deliver this and to take this to further stages, what we really need is a different kind of agent. I talked at the beginning that we had to use titanium nanotechnology in the first study that I've described to you. We're now trying to work very hard in conjunction with our chemical engineering colleagues to try and work out if we can produce an agent which will give us both the sustained release that we want, but is preferably something that's resorbable. In addition to that, we've given them a bigger challenge, is that we'd like not just something that we can pack our magic proteins in to give us the sustained release, but we would like to have something that we can inject, because that will be a much easier way of trying to produce this into translating this into human practice. And preferably if we could inject it as a liquid, and then within the body, the liquid turned into a solid, which would then give us a much slower and sustained release. Now, this is keeping our chemical engineering colleagues very busy. They're busy trying to work out how they can do that, and they're working with all sorts of different types of polysaccharide molecules and dextrans using a wide variety of different molecular weights from 10,000 Daltons right the way through to 90,000 Daltons in different mixtures. I have to say that we've asked quite a lot in trying to set the standards, saying we want something that's injectable, but we want it to have sustained release. And it means that temperature control is really important. And one of the things that was news to me, and I suspect maybe news to some of you who are also clinicians rather than engineers, is that I hadn't realized that you had to do many of these experiments in rooms like this, which is a constant room, 37-degree room. So you can actually work out on how the amount of fluidity of your substances, whether it's liquid or whether it's solid. So a lot of these experiments require very careful environments in undertaking these studies if they're going to be reproduced at a human or animal level. Just to say, on the right-hand side, further on the screen there, is just some experiments which show the amount of diffusion that occur, and what it very simply shows is that the smaller your dextran molecules are, then the greater the diffusion. But this whole concept of trying to have something that we can inject that becomes a solid and then slowly dissipates as our therapeutic agent is released is something that could be of enormous benefit, not just here, but has multiple other medical applications. And therefore, that's why we're investing quite a lot of time in trying to see if we can alter it that way. So in conclusion, making sure we've got time for questions, is you could see that really trying to use nanotechnology in trying to use it both to help undertakers in our scientific studies to try and develop therapeutic agents. We really need to work with a combination of different skill sets. We as clinicians need to work very closely both with the scientists, with the developmental biologists and the molecular biologists, but also with the engineers and particularly the chemical engineers and nano engineers to try and work out the clever or potential agents that the scientists come up with can actually be delivered in a meaningful way that may translate into clinical practice. I'd like to say thank you all to you all for your kind attention. And just to show you the little baby that I showed you right at the beginning, which was, as I demonstrated rather nicely, what is our key problem, is here she is, she's growing up. As you can see, the middle of her face is now continuing to not grow as much as the rest of her. She's developing the class 3 malocclusion that I described was likely to happen, and she's got still a little bit of proptosis. But if we're hoping that when it comes to her children, that we might be able to treat that with medical management using nanotechnology to deliver drugs that would and agents that would stop or reduce the need for her surgery. So I thank you all very much for your kind attention.
Thank you, Dr. Peter Yona, for your nice presentation about nanotechnology to manipulate future biology. Maybe we have a question and answer right now. Okay.
I have to say it's quite hard on a Saturday afternoon.
Yes.
Nanotechnology and molecular biology are not the easiest topics.
Yeah, you're right. It's very. Maybe one question, Dr. Peter.
Yeah, sure.
How wide this critical size defect we can use this nanotechnology?
Yeah, if we're using it in murine models, you could. There is some disagreement in the literature. We found that 3 millimeter reliably gives you about 50% of your defect will be healed at 3 months.
3 millimeters.
Some people have quoted using 2, but when I tried doing those experiments with using 2 millimeter defects, I found that they nearly all healed by 3 months.
Okay, that's nice. And
but for those of you that are reading the topic, there is some disagreement in the literature on that.
Okay. And then the second, what age baby with a Crouzon syndrome have can do this nanotechnology?
Yeah. What we're hoping for in the future is currently our only surgical option is to firstly make the brain box bigger at a year while the brain is growing very rapidly, because as I'm sure you'll all remember, the brain is almost adult size by the time a child is 2. So what we're hoping to do is that if we could give localized, what we would like to do either with implants or preferably with if we can develop it in time, the hydrogels would be to inject over the suture when the baby is first born or in the first few weeks of life, and to stop those sutures from fusing so that the brain can grow without the fused suture, without it being inhibited by fused sutures. And that would reduce the need for major cranial surgery in a baby in the first few months of life.
Oh,
so it could radically alter the way that we deal with things. Similarly, with the sutures in the face, the malar maxillary suture and the midline maxillary suture, if we could give local therapeutic agents to that, then we may stop the need for doing a Lafore-1 or a Lafore-3 osteotomy when the baby grows up and is at 14, 15 years of age.
So we can reduce the osteotomy for the baby?
Absolutely, yeah. But it would mean we need to start treatment for a baby in the first few weeks of life. But it potentially, yes, you could stop them having the major operation, potentially life-threatening operation, which is our current practice.
Okay, thank you.
So that would be a huge change.
Yes.
Yeah.
It's a big. Maybe there's one question from Dr. Lelia.
Yeah.
She's asking about from these all materials for this, for the manipulation, which one is the better for?
Well, I think it would be if we could get a resorbable material that would actually work reliably and do what we want to do and give us sustained release. I think a resorbable has to be better than something that we have to leave in situ, particularly as you'll be leaving it close to a child's brain, which is less than ideal. We do it at the moment because when we do our cranial surgery, we leave titanium plates and screws there. But if we had something that was resorbable, that clearly would be better.
Okay.
But at the moment, our resorbables won't give us enough sustained release of our therapeutic agents to allow us to do that.
Okay, thank you.
It's changing. In 5 years' time, I'll probably give you a different answer. Maybe
thank
2
you
years'
for your
time.
answer. That's a nice research for us. Maybe another question again from the participant. We don't have. Maybe another explanation again, Mr. Peter.
Sorry?
Is there any explanation again for this nanotechnology for us?
I think there's plenty of use. I think where it would be really nice is in children who've got various medical conditions where their oral health is compromised. It would be really good to think about whether we could have perhaps localized slow release of fluoride. Could be a huge application in the dental field. So children, particularly those that have, for various reasons, particularly if they've got cerebral palsy or reasons where oral hygiene is really difficult, or they've got poor salivary flow, then local release of agents could have a huge impact on dental health. So I think there's quite a lot of potential lateral applications in this technology. And I think all aspects of dentistry therefore could be impacted.
Yeah, I hope all surgery, maybe we can reduce the surgery for the babies.
That would be good, wouldn't it?
Nanotechnology.
Well, so I think conservative dentistry and prosthodontics obviously would be impacted if we could have something to help to control caries, and potentially perio as well if we had agents which again altered the microenvironment.
Okay.
So I think this is a very important topic within the dental field. It's a question of how do we harness the technology to actually use it and to deliver the agents that we want that will alter oral health.
Thank you, Dr. Peter, for your explanation.
Yeah.
Maybe Dr. Isra, if we don't have any question again, and then thanks to Mr. Peter.
Thank you very much. Thank you all for listening.
Thank you, Dr. Peter. Next session is certificate delivering by moderator for Dr. Peter. Okay.
Okay, Dr. Peter, this is a certificate for you in recognition as a speaker of main lecture in ICO-BTD, the fourth ICO-BTD, held by Dentistry Faculty of Hasanuddin University. Thank you again, Mr. Peter, for your kindness. So, Dr. Isra.
Thank you, Dr. Peter. Are you still there? Okay. Once more, I want to thank you for Dr. Peter for the nice explanation this afternoon. And Dr. Abul, we should continue this session with the next speaker. But before we continue, maybe we're going to the video again. Okay, ladies and gentlemen, distinguished participants, please check it out.
Sensodyne Repair and Protect is a daily toothpaste for the treatment and prevention of dentine hypersensitivity. Sensodyne Repair and Protect contains Novamin, an advanced calcium and phosphate bioglass technology. A single Novamin particle ranges from about 5 to 20 micrometers in size. New Sensodyne Repair and Protect also contains sodium fluoride. The unique formulation has been developed so that both the Novamin particles and sodium fluoride are protected in their active form and available when brushed with in the mouth. When Novamin comes into contact with saliva, it releases calcium and phosphate ions to build a hydroxyapatite-like layer over and within the dentine tubules. This begins with an ionic exchange between sodium in the Novamin and hydrogen ions from the saliva. This ionic exchange causes a small localized rise in pH that promotes formation of hydroxyapatite. Novamin particles can bind to collagen fibers in dentine. Once deposited, these particles continue to react and act as a calcium and phosphate reservoir to build a hydroxyapatite-like layer over dentine and within the dentine tubules that also incorporates fluoride. This hydroxyapatite-like layer is chemically and structurally similar to biological apatite, forming the inorganic portion of dentine. The reparative layer formed by Sensodyne Repair and Protect starts to form after the first brushing and promotes the dynamic mineralization of dentine to build a substantive reparative layer over the dentine and within the tubules, which in turn reduces dentine permeability. Decreased permeability can relieve dentine hypersensitivity by decreasing the fluid flow within tubules, thereby reducing the activity of nerve endings. Sensodyne Repair and Protect delivers clinically proven relief from the pain of dentine hypersensitivity with twice daily with Repair and Protect.
Thank you for watching, and just for your information, the 9th session of the 4th International Conference of Biophysical Technology in Dentistry, supported by GSK. So for Dr. Abu, please continue the session. Thank you.
Thank you, Dr. Isra. Dr. Aching, this is our last presenter for today.
Yeah, sure.
Dr. Aching is a lecturer from dental faculty dentistry in Hasanuddin University, and he was graduate from Hasanuddin University as a dentist in 2008, and then in 2017 he got a Ph.D. from Okayama University, and 2020 he just passed for prosthodontia specialist in Hasanuddin University. His presentation about a new perspective of Bruxism. First, maybe the second presentation, Dr. Aching. What is the title?
Yeah, so actually I have two topic today. So the first topic is about the denture adhesive.
Okay.
And then the second topic about the Bruxism.
Okay, Dr. Aching, the two topics today, we have 45 minutes to get your presentation, and then we have question and answer about 15 minutes later. Maybe time right now, time is yours.
Okay, yeah, thank you very much, Dr. Abul. So, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. So today is the last day of ICO BTD 4. So thank you very much for the organizing committee who have hard work to arrange this meeting. And then today, I would like to present two topics. The first topic, as I thought previous, it's about the denture adhesive, and then the second topic is about the Bruxism. Is there any possibility of a new paradigm of Bruxism? Well, so let me share. Allow me to share my presentation. Okay, search. So can you see my screen, Dr. Abul?
Not yet, maybe a little bit more.
Yeah, maybe still a little bit.
Yeah.
Need the time.
Okay,
Is it okay? Thank you very much, Dr. Abul, and then organizing committee. So, as the because this meeting is supported by GSK, so allow me to present a topic about the denture adhesive. So I will talk a little bit about denture adhesive. So as a dentist, I think most of the participant is a dentist, and then also specialist in prosthodontic as well. So we already know that the denture, it's very important. It's very important to rehabilitate the quality of life, the social interaction, and general health. So as a dentist, I think you already have experience to make a denture. So what make the denture performance good? For example, the denture should have a good retention, stability, support, and comfort. And then, of course, the denture should be rehabilitate the mastication of the patient, so the patient can chew and carry out the daily life confidently. And then in the next screen, so we will have like the experience of some patient who have used the dental adhesive. For example, like this patient. So this patient has a diabetic type 2. So as we know that the diabetic type 2 has a bone resorption. It's different with the normal person. So in bone resorption, it's difficult. Sometimes difficult to get denture will fit well with the anatomy of the jaw. So this patient also has a small lower jaw. So for making a denture, also that's a challenging situation, how to make the denture fit to this patient. So let's see. So in this patient, when she use a denture adhesive, the denture adhesive can may improve the retention of the denture, and also after use a denture adhesive, it can make a denture more stable, and also could manage the gradual of soft and hard tissue, as we know that in the bone loss or in the edentulous loss, the soft tissue and hard tissue changes for of a life. So we still have some experience from another patient. So this patient has a kind of serostomia. Serostomia, as we know that the patient doesn't have much quantity of saliva. So the mucose without saliva can make the denture not fill, and then it can make the mucose something like inflammation in the mucose. So for, as we call, the denture related pain. So in this patient, after examination, it seems that this patient have a dry mouth, and then a minor denture sticking. So this is also the indication for a patient who has a serostomia. So actually there are some alternative treatment for the serostomia. For example, to make artificial saliva. So this is also the option if the patient doesn't have time to make the denture with artificial saliva. So the patient can use the denture adhesive. So we, as a dentist, I believe that we already knew that the cause of xerostomia as well, because it can be caused by medication, radiation therapy, also systemic disease, and then xerostomia or loss of saliva can limit normal denture retention. So the primary function of saliva for the denture is about retention. So if the oral mucosa doesn't have much amount of saliva, so it can make the denture is not fitting well. So as shown here, as shown in the screen, about the viscosity of the saliva. So viscosity of saliva contribute force, which again the any movement. So if there is a viscosity of saliva enough for the denture, so it can make the denture fit, and then it's again the any movement which can make the the denture move to the right, to the left, and another side. And then yeah, it's also for surface tension and border seal. So this is also the function of the saliva. So for example, for surface tension, the liquid surface tension can minimize the area of the free surfaces, so generating familiar curved surface of raindrop and eminis. And then border seal, so the saliva can maximize the effect of surface tension in the viscosity. So after use denture adhesive, we make some questionnaire, and then we got some conclusion that patient with the xerostomia, it may have a good denture by using a denture adhesive. That's one of alternative point for the xerostomia. And then some patient also said that they intend to continue usage of denture adhesive under medical supervision. About the retention and the ability to chew, we already know that in the xerostomia patient, after using a denture adhesive, it can increase the retention and also the ability to chew. So we still have another kind of patient. For example, immediate full denture. So sometimes in patient who will have a denture, but he still need a time for the making the denture. So after several days, maybe the patient experience that the denture is not fit well. So in this case, the denture adhesive can be used. So according to the research, it shows that 32% reduction in the horizontal bone dimension after use the dental adhesive. So bone resorption after tooth extraction is, as we know, is accelerate. It's very high during a year, and then it's gradually decreased. But according to this research, the reduction can be minimized. So we also have a patient who use a partial denture. So as we know that partial denture partial denture, it's have like a clasp in the which hold to the remaining teeth. So sometimes if the patient have a denture is not so adapted to the teeth, so sometimes it's not unsuitable, and then sometimes it's a loss of retention. So in these cases, for the first step is to make a denture or to repair the denture so it can be fit to the teeth or the mucous. But otherwise, if the patient doesn't have much time to repair the denture, so the patient can use this denture adhesive. So in case of a partial denture, when the natural teeth abutting the denture, it can the natural teeth may moving mobile, but after use the denture adhesive, so it can prevent the natural tooth to become more stable. Yeah, we still have some experience from another patient. So sometimes patient is not ready to have a denture. So when she has a good teeth, she has a good adaptability to chew and another function. But when the patient should have a denture, so sometimes patient have another perception. So it's something like an unrealistic expectation. So in this patient, for the first use of the denture, it need it need time to adapt with the new denture. So in this time, so in this case, the patient, if they use a denture adhesive, so the patient can have or may adapt well. So as we know that the first denture, in the first experience of denture, many patients may complain that there is a food or remaining food trapping to under the denture. Yeah, so what the denture adhesive can perform for the new denture is denture adhesive may help to seal out food from the denture. Also, it may improve the retention of the new denture, and then it can help the patient to improve the experience of using denture. So when we use a denture adhesive in this stage, so it may improve the patient the patient like improve retention, and then also help seal out of food which trapped under the denture. So after we see the cases, so we can conclude that after using the denture adhesive, it may increase the retention, stability, and masticator efficiency, and also may increase the comfort of the patient who use the denture. And the second is it may help to seal again the food which interact between denture and mucous. And also denture adhesive may coverage for all around seal. So this is the three mains the purpose of the denture adhesive, that we can use. So also, according to another study, there are some study which is focus on denture adhesive. So denture adhesive may increase retention and stability of the best fitting denture, and then it may increase bite force up to 38%. As we know that the person who use a denture, so the bite force will be lower compared to the natural teeth. And also, when using the denture adhesive, it may hold the denture until 12 hours. Of course, because the denture can stay for a long time, so that it may improve the patient comfort. So maybe this picture, I think we already see in the movie that there are food entrapment under the denture, but when use a denture adhesive, we can when we use a denture adhesive, so we can see that food entrapment, it's only in the border, but without adhesive, the food may entrap to the below of the denture. This is also the microscopic appearance when using the denture adhesive or not. So based on the study, there are 86% of patients who use a denture complain of food trapping under the denture. So so for who want to make a good denture, so I think it should be in the dentist and should be in prosthodontic as well. But if you have, if patient have a complaint about the denture is not fitting well, so you may use the denture adhesive. So this slide, so how to use the denture adhesive. So this is a brand of Polydent. So at the first, the patient should make the denture clean and dry, and then patient may apply a small amount of denture adhesive and not to close the edge of the denture, so it can be to all around of the surfaces. And then the last step is, before using the denture adhesive, the patient should rinse their mouth with water, so it's make remove the saliva from the mucosa. So that's the 3-step how to use the denture adhesive. So this is also a guidance for the simple step of how to apply. So at the first, don't forget to use a small amount, and then put to your mouth firmly, and then when you are asleep, so the patient not need to use the denture. And then this is also important, a very important point is the patient have to visit the dentist regularly. So this step may assure that the patient denture may fit, and then can be used for last longer times. Okay, I think that's all for my first presentation. So I would like to move to another presentation, another topic. Okay, so this is my second topic about the Bruxism. So I think Bruxism is not something like a new topic, but the Bruxism has been studied for a decade. So we already know what the Bruxism is, but in this presentation, I try to my perception about the Bruxism. So let's we look what. Okay, so my second topic is about Bruxism. So we already know what a Bruxism is. So I think I don't need to explain more detail about the process, but as I saw the participant in this meeting, all of them are dentists, and then we learn about the Bruxism when we was in the school, and then during the symposium and seminar, there are so many topics about the Bruxism. So this is the video, so we can imagine what the Bruxism is. So the Bruxism is the movement of the mandible to the left or to the right, also to vertical, to the vertical. So let me discuss a little bit about the introduction. So actually the Bruxism is coming from the Greek, means tooth grinding. So in the 1981, Bruxism described involuntary excessive grinding, clenching, or rubbing of the teeth during non-functional movement. So here we have a keyword about the non-functional movement. So Bruxism is referred to movement of the jaw that are outside of the normal functional activity of the teeth of the jaw. So we already know also about what is the normal functional. Normal functional of the jaw is speaking, chewing, and swallowing. So the activity is other than this example. So it's included to the non-functional activity. So functional activity is including speaking, chewing, and swallowing. And then about the definition about the Bruxism. So actually Bruxism is become the interesting topic for many decades. In the 1966, Ransford et al. Defined Bruxism as habitual grinding of teeth where the individual is not chewing or swallowing. It's mean that this is non-functional activity because this is explained that habitual grinding is not chewing and swallowing. So the activity beside chewing and swallowing. And another study also says that in 1986, Rubina defined the term of Bruxism to indicate the non-functional contact of teeth, which may include clenching, gnashing, grinding, and tapping of the teeth. So maybe some of us still confused about what's the clenching is, what the grinding is. So we will discuss later. So also in 1995, Van der Ras defined a Bruxism as non-functional movement. So this is non-functional, and another description is also about non-functional. So we already clear that the Bruxism is a non-functional activity. And then from the American Academy of Sleep Medicine, they define the Bruxism as a repetitive jaw muscle activity characterized by clenching and grinding of teeth or bracing or thrusting of the mandible. So it's mean repetitive jaw muscle. It's mean that this activity is frequent. It's not only once, but maybe more than once. So it's mean the repetitive jaw muscle. So we has discussed about the parafunction and functional activity. As I said before, that functional activity is chewing, swallowing. So it's all about the functional. And another activity beside the functional is a parafunction. So, so why the parafunction is more harmful or more risk to damage to the stomatognatic system? Because in here we can see, for example, force of the tooth contact. In the functional, when we eating, so the force is just about 17,000 pounds, but for parafunction it's more than functional. It's about three times higher. The forces was 2 or 3 times much higher than the functional. So we can imagine that the force is very high in the parafunction activity. And then the direction of applied force of the teeth. So when we eat food or something, so the direction of force is vertical, and then this force is well tolerated because we has the gementum of periodontal below the teeth, but it's not the same with the parafunction. Parafunction, the direction much more horizontal, as we know that for the horizontal activity, it can make the tooth can move something like we call it mobile. And then the mandibular position for the functional activity, it's centric occlusion, but the parafunction is eccentric movement. So from this difference between functional and parafunction, we can imagine that parafunction is much more danger from our stomatognatic system. So in the previous slide, I talked about clenching and grinding. So I think much, or maybe the participant is already understand what the clenching and grinding is, but let me explain again about what the clenching and what the grinding. The clenching is forceful closure. So in this picture, forceful closure of the opposing dentition in a static relationship of the mandible and maxilla in either maximum intercalc or an eccentric position. So clenching while clenching activity while the teeth upper and lower is occlusion. So when there's a contact between upper and lower teeth, so that's a clenching. So when there is a force here, so it's mean that the muscle around the lower jaw is a contract, because there's a contraction of the muscle. So this is a clenching, but clenching is static activity. So we can see, for example, when somebody has a emotional stress, so sometimes they perform clenching. So just like make a force between teeth. So that's a clenching. How about grinding activity? Grinding is it's the same with clenching, but the activity is horizontal. So there is a movement. From the mandibular arch. So it's grinding may have something like a dynamic maxillomandibular relationship. So the mandibular move to the right or to the left. So that's grinding. So not not static but dynamic. So the jaw is moving. That's a grinding. The grinding we can see in the sleep bruxism person. So if there is a noise of sleep bruxism, so it refers to grinding activity. So how about the prevalence of sleep bruxism? There are many studies reported the prevalence of the sleep bruxism, and there of the data also much varies between one study and another study. But from the study, we may summarize that sleep bruxism is much more happen in children. Yeah, it's much more happen in children. So it's around from 7% to 88%. So that's the prevalence of the children. In adolescents or teenagers, is gradually decrease. Also in adult, it's continued to decrease. So we can conclude that in children, the prevalence of sleep bruxism is much more higher than another age stage. So this topic also similar with the previous topic by the honorable speaker, Dr. Marhamah, talked before about the bruxism in children. So the prevalence of the bruxism in children is much higher than any other age stages. And then so there is a question. So why in children the bruxism prevalence is higher? So there are two theories. There are two theories try to explain why the children is conduct bruxism more than another ages. So one theory about the how bruxism start in children is the occlusion instability. So as we know in children, they are like a mixed dentition. There are primary teeth, and there are also permanent dentition. So in children, the occlusion is not as stable in adults. So the teeth try to find the best fit for occlusion. So that's why in children, bruxism is much more happen because the occlusion instability. And the second reason is why in children perform bruxism much more than another age. In this study, they said that in younger children, bruxism may be due to the immaturity of the masticatory neuromuscular system. So because the neuromuscular system is still developing in children, so the immaturity of the masticatory neuromuscular system affect the bruxism activity in children. So I underline the point for the why the prevalence of the bruxism in children is much more higher than another age. And then, so we move to the etiology of the sleep bruxism. So as we need to understand that the bruxism etiology is controversial phenomenon. So it may involve many factors, or it's multifactorial. And some reference address that the etiology factor basically only two groups. For example, peripheral and central factor. So we can see in the next slide. So the possible etiological factor for sleep bruxism. So in this study, the author divide the etiology of sleep bruxism by two factors, the peripheral factor and the central factor. The peripheral factor, for example, facial morphology, condylar asymmetry, dental arch form, malocclusion, as we can see in the children, and then centric dilation, maximum intercuspation, and etc. And how about the central factor? It's divided by two, pathophysiological and psychosocial. For example, a sleep disturbance or a sleep arousal, and then a smoking and allergy, and then for psychosocial. So psychosocial factor for bruxism, we easy to find in the article. So many article study about the correlation between anxiety, stress, and another psychosocial factor to the sleep bruxism. And then, so in the few decades, so the investigator just focused to the sleep bruxism, and then the time the study of about the sleep it's very common for the to investigate about the bruxism. So this picture show about the sleep stages. So I think we already know also about the sleep stage. So when we sleep at night, or maybe at night, so there are a cycles of the sleep. So one cyclus it's around 90 minutes. So it's divided by two actually, non-rapid eye movement and rapid eye movement stages. So it's divided by two main, for example, non-REM and REM, rapid eye movement. So when we sleep, sometimes we can see in the lid, in the palpebra, so we can see that the eye is moving. The eye is moving. So that's the sign of the rapid eye movement. So this is a one cyclus of sleep. So at the first when we try to sleep, there's a stage one or lightest stage. It's occur 1 to 7 minutes. 1 to 7 minutes. What's happening in these stages? Heartbeat slow down. So our heartbeat is start to slow, and the breathing is start to slow. Eye movement also slow down, and the muscle start to relax, and brain waves begin to slow down. So this is the lightest stage of the sleep. So this stage one occur from 1 to 7 minutes. This is the first stage of sleep. The second stage of the sleep is a light stage. So it's occurred 10 to 25 minutes later. So the first stage is 1 to 7 minutes, and the stage 2 is 10 until 25 minutes. So what's happening in this stage 2? So from the heartbeat, breathing, eye movement, muscle, is gradually down, gradually decrease in the stage 1, in the stage 2. So in the stage 1 is gradually decrease, and then in stage 2 is more decrease. I'm sorry. So the bruxism it's much more happen in the stage 1, in stage 2, because there still have a brainwave activity. Even the brainwave activity is start to decrease, but it's still still working. How about in the stage 3? Stage 3 is the deep sleep. So in these stages, even there is a sound, a big sound, big sound. So the subject or the people will, still in sleep condition. So it's not annoying by anything. And then in this stage 3, heartbeat and breathing is become to the lowest level. This is the lowest level of the sleep for the heartbeat and breathing, and the muscle stay relaxed and brain waves slow down. So this is gradually, and the stage 3 is the most and the lowest level of the heartbeat and breathing. So in this stage 3, according to the literature, bruxism is not happening in this stage 3. And then the cycles of sleep continue to the stage 4. Stage 4 is identified by the movement of the eye. So this is a rapid eye movement. So we can see a person after this stage. Then they will have the eyes will move to left to the right. Is involuntary, and then this is a stage 4. It's around 20 to 40 minutes. So in this stage, according to some literature, when we dreaming about something, about anything, it's happened in the stage 4. It's happened in stage 4. So in this stage 4 also, the bruxism may happen. So bruxism, sleep bruxism, is happen in stage 1, stage 2, and stage 4. So in the stage 4, the heartbeat and breathing is become irregular. So not lowest level anymore, but it's try to increase, but irregular. And then heart rate increase, and the blood pressure also increase. And the next stage is awake. So after the stage 4, so the person is awake. So this is a one cyclus of sleep. So for one cyclus, it's happened for 90 minutes. So during our sleep in one night, it's around 4 until 5 cycles of sleep. So in stage 4 also, the metabolism, recovery, and then memorial restored. So if we dream in this stage, so and then we wake up, so sometimes we still remember what the dreaming, what our dream in these stages. So as you can see here, that about the study published in Oral Rehabilitation, that 80% of sleep bruxism episode occurred in stage 1 and stage 2, and around 5 to 10% in stage 4. In stage 4, I think sleep cycles is interesting to study, and we can understand about the metabolism our body. So when we understand the sleep cycles, so we we may understand why we need to sleep, why we need to take rest, because this is important to recharge our energy, and then yeah, as well. Now we move to the bruxism symptoms. So in the bruxism person, we can see much person with bruxism has an anxiety, stress, and also tension, depression, earache because the mandible is moving, and then they will have a fatigue in the joint. So because ear is near from joint, so the patient may complain about earache, and then eating disorder, a headache. Headache we can understand well when we see the movie. So why the bruxism and the headache has a correlation, and also hot, cold, or sweet in the teeth. So this is makes sense because when the person bruxism, so the email may damage so it can damage the email of the teeth. Insomnia or difficult to sleep. And then the last is sore or painful of jaw. Yeah, this is I think this already understand. So why the jaw may painful in bruxism. So this is the video. Maybe similar with the last video, but in here, so here we can see when the bruxism activity, the muscle contract, masseter and temporalis and pterygoid lateral is active when the bruxism happen. So that's why. So let's try to move again. Okay, so wait a minute. So let's see the video once again. So when the bruxism happens, so you can see the masseter muscle, temporalis muscle is contract, and another muscle is pterygoid lateral inside the masseter. So that's why when the jaw is active and bruxism occurred many times, the patient with the bruxism will have a symptom of a pain in the jaw, pain in the head or headache. So this temporalis muscle make a contraction many times. So in patient with bruxism, sometimes also have a headache, or in some journals said that this type of headache is tension type headache. So the classification of headache because of the bruxism is tension type headache. So somebody perform bruxism, so all the muscle here, temporalis, masseter, and pterygoid lateral will contract. So it makes sense. We can understand so why the people with bruxism has a headache as well. Okay, now we move to the diagnosis, the bruxism. So when we has a patient with bruxism, so don't forget to make a good anamnesis, because for the bruxism, history is very important. History is very important. The point is the muscular tenderness in the morning. So this is the very, very characteristic about the bruxism. So if we have a bruxism, so one point that we can ask to patient is, do you have a tenderness or do you have a painful in your face in the morning? So So if the patient say yes, so we can make actually not a conclusion. So we can move to the next of diagnosis of bruxism. So this is very important. History is very important. But sometimes for the sleep bruxism, the subject is not aware that she or he has a bruxism because she sleeping. So we can ask the sleep partner or parents of the patient. So, for example, she has bruxism. She has a noise when sleeping. So if the parents of the sleep partner say yes, so we can what I say. So may they have a bruxism activity. For example, in children, so we can ask the parents, is their children has painful in the face in the morning when they wake up in the morning. Sometimes they will have a pain in the face, and then from the history we can move to the examination. So what we can see in the oral mouth cavity, so we can see the wear facet on the occlusal table or evident. I mean, it's mean that there is a wear facet in the email, and then we can use the articulating paper to underlying occlusal disharmony. So just to make sure. So actually, the examination is not only for the teeth, but also for the mucous. For example, somebody I read in one article about the collaboration between horizontal line alba and bruxism. They said that there is a correlation between bruxism activity and line alba because when bruxism happen, they may bite the cheek, buccal side of the cheek. So that's why there is something like line alba, horizontal line alba in the patient with bruxism. About the manifestation. So of course, the sign and symptom of bruxism is depend on. So this is I would like to underline the sign and symptoms of bruxism is depend on how many frequencies of bruxism, and then how about the intensity of the bruxism, and then how long the bruxism associate with the age. So we can see the duration of habit, how long the bruxism. So this is important that the sign and symptom of bruxism is depend on the frequency and the intensity. So we will discuss later about when the bruxism is harmful, or when the bruxism is still in normal scale. So what can we do to examination about the bruxism activity? So because the bruxism is a moving muscle, so we can examine the muscle. So there are two devices it common use to examine the muscle. One is polysomnography and the other one is electromyography. So polysomnography is actually of gold standard for the bruxism. But polysomnography has a limitation to adapt to conduct. For example, because Ph.D. need sleep laboratories, so need special room to conduct this activity. And then, of course, it's expensive. And then the subject with bruxism need to stay longer in the sleep laboratory, because usually the measurement or examination of the muscle is not conducted at the first night, because the first night is for adaptation. So the subject should stay at sleep laboratory at least 2 nights. So the first night is for adaptation, and the second night for the examination. So based on the limitation of this polysomnography, some inventor create electromyography. So this is simple. It can be used not only during sleep, but also during awake, because the device is small and may allow the subject to do their daily activity. And of course, it's not expensive. It's inexpensive. So in polysomnography, according to the study by Levine, they have a diagnostic cutoff criteria. So when the subject is called as bruxer or not bruxer, so there's a cutoff criteria when the subject is we can classify as a bruxer and non-bruxer. Bruxer is if they have a 4 bruxism episode per hour. So during 1 hour, is there more than 4 bruxism episode? How many times the bruxism happened in 1 hour? That's the first. And then the second, and more than 6 bruxism bursts per episode, or 25 bruxism bursts per hours of sleep. So this is also criteria. So there is a 3 criteria to classify that the person has a bruxism and the person doesn't have a bruxism. I mean that doesn't have bruxism is a normal subject. So and the last cut-off criteria is at least 2 episode bruxism with grinding sounds. So this is important. So if the subject has at least 2 episodes of bruxism with grinding sounds, so it can be classified as a bruxer. So this is a cut-off criteria of the when we use a polysomnography. So we still have another slide. So this is for electromyography that we conduct to measure the muscle. So what the clinical feature of the bruxism? For example, we can see the occlusal trauma. Occlusal trauma may resulting in mobility more in the morning. So this is interesting also. So maybe we have a patient has a mobility of their teeth. So if the patient doesn't have a periodontal disease, so we can anamnesize this patient. Does she or he has a bruxism activity or not? Because the bruxism may result in teeth mobility. And the second is tooth structure. So that we can see a sensitivity, a typical shiny, wear facet with sharp edges. This is also typical characteristic of the bruxism. So probably pulpal exposure, or maybe crack of the crown and the restoration. And the third is muscular tenderness. So as you saw in the video, when the bruxism happened, the lateral pterygoid, masseter, and temporalis is contract. So it can make fatigue on working. So when wake up in the morning, so it's something like fatigue or pain in the face, and also hypertrophy of masseter. So we have a patient in a prosthodontic department. So at the first, when I saw the patient, so I saw that there is a the cheek is like chubby. Yeah, it's like and then at the first sight I can assume that she might have a bruxism activity, and then when we make examination, so we get the truth that the patient has a bruxism activity. So the masseter is become bigger, hypertrophy. So it's the same with the football player. So when they use foot many times to play football, so the muscle become bigger. So this is also the clinical feature, something like TMG disturbances, cavitation, clicking, restriction of mandible movement, deviation of chin, pain, headache. Headache we also notice in the movie, and another sign of symptoms. I'm sorry. So their study classify the sleep bruxism consequences by biological, physical, aesthetic, and others. So I think this is the same with the previous. Slide. So it just classify by for biological, what's happening in biological, hypersensitivity, hypermobility, hypersomatis, etc. For physical, there is a tooth wear, abrasion, implant failure, and aesthetic, others, and etc. So I think it's the same with the previous slide, but more detailed because it's classified. So what kind of treatment that we can use to the bruxism, to the bruxer? So from literature review, there is four treatment that we can use, that we can perform to the patient. For the first is occlusal therapy or occlusal adjustment. So this is to type occlusal therapy and occlusal adjustment. Occlusal therapy means the occlusal spin, and occlusal adjustment mean that we change the anatomical of the teeth. So that's the occlusal adjustment. So I think this is also has explained by the previous speaker about the bruxism in children. And then the second is behavioral therapy. Behavioral therapy, because the treatment is much more correlated with the stress, anxiety, and tenderness. So we need to do a behavioral therapy in such patient who has anxiety and etc. And biofeedback therapy, this is also makes sense if we conduct in the bruxism patient, but as far as I know, in Makassar we doesn't has a biofeedback device. And then a pharmacological therapy. So some bruxism patient has pharmacological therapy, for example, diazepam on injection of botulinum toxin type A. So this is what I want to discuss a little bit about the new paradigm of the Bruxism. So in the previous slide, we only noticed about the sleep Bruxism, sleep Bruxism. So maybe is there any another Bruxism that we need to know? So it's the new paradigm is started from my study about 4 years ago when I conducted a study in Hasanuddin University student. So I use a electromyography device to around 200 students. And at that time that was a bigger sample for electromyography. So this result is might be worth it. And then this is the device electromyography. So we measure the masseter muscle. We put electrode to the masseter muscle, and then we record the activity of masseter muscle during sleep and during awake and during sleep. So we conduct in student, around 200 students, and then we put the electrode from in the early morning until wake up in the next morning. So it's around 23 hours. Then 22 until 23 hours use the recording, the electromyography. So we analyze the muscle type activity. So for example, basic, tonic, and mixed. Okay, so this is the result of the sample of the result of muscle activity. So this is activity during awake, and then this is the activity during sorry, let me. Okay, so the bottom, I'm sorry. This is muscle activity during awake that we analyze from the recorder, and this is a muscle activity during sleep. So you can see the differences between awake and sleep. So this type is a Bruxism activity. So this is one episode of Bruxism, and then continue with nothing muscle activity. But in the activity during awake, during day, so there are so many muscle activity recorded to the patient. So we can see that much more muscle activity happen during awake than during sleep. But in few decades ago, so we only focus to the sleep Bruxism. We didn't aware about what kind of activity happened during awake. But from our result, we found that during awake, much more muscle activity investigated, so appear during awake. So this is also Bruxism. So this is this record during sleep. So from in the middle of the night until early wake up in the morning. So this is the final result. So this is the result from subject the first when we put the electrode until subject go to the bed. So the duration is much more longer than awake than sleep. So this is a muscle activity during awake. This is a muscle activity during sleep. We can see the differences between awake and during sleep. Okay, so we move to the next slide. Then when we try to illustrate the muscle activity. So it's clearly seen that in here, this is activity during sleep, and this is activity during awake. So there are so many muscle activity during awake. So this graph shows the frequency. I mean, how many times the muscle contraction, during awake, and how many muscle contraction during sleep. So you can see the difference. It around 2 or 3 times higher, 2 or 3 times more frequent in awake than sleep for the frequency. And how about the duration? The muscle activity, the duration of the muscle activity during awake. This is the muscle activity during awake, and this is the muscle activity during sleep. We can see the differences that the muscle activity is much more during awake than sleep. It's around, it's in 3 times longer duration of muscle activity during awake than during sleep. So from this result, it's challenged me to investigate about the awake bruxism. So because we only notice about the sleep bruxism, but in the recording we see that the muscle activity is much more less in the sleep. So why we focus to the sleep bruxism, we need to making much effort to the awake activity as well. So this is the conclusion: muscle activity much more performed during daytime, during sleep. So we need to be focused to the, and we need to be much more aware about the awake bruxism. So this is also diurnal or awake muscle activity. This is my actually this is my opinion. Diurnal muscle activity or awake muscle activity is much more potential or harmful for oral heart tissue damage, failure of dental restoration, and temporomandibular disorder. So based on what we conduct research, so I conclude that, maybe not conclude, but I suggest that diurnal muscle activity is much more potential for destroy stomatognatic function. And then when I try to find some literature about awake bruxism, so actually awake bruxism is it's new topic about the bruxism, because we just notice about the sleep bruxism. As we can see, the prevalence for awake bruxism is around 22.1% until 31%, and sleep bruxism it's only 13%. So awake is much more prevalent than sleep. Muscle type in the awake is much more clenching, and the sleep clenching and grinding. So this is similar actually, but in the awake, because stress emotional is much more conducted during our daily activity. So the stress person is much more perform clenching. So what the examination can be performed for awake and sleep bruxism. So we can use the questionnaire, we can use the Ph.D for the sleep, and electromyography for both. And then the duration possibility for awake bruxism is around 14 hours, and sleep is around 8 hours. So 14 hours mean that when we wake up in the morning until we go to sleep is 14 hours. So in the longer duration, we may conduct awake bruxism. Compared to the sleep, it's about 8 hours. So I think my conclusion is goes to, based on the duration and number of muscle activity during awake day. So I'm thinking that bruxism during day need to investigate, and may be more harmful than sleep bruxism. So thank you very much for your attention. If you have any comment and question, so please discuss. So I put to the Dr. Abul. So please, moderator, maybe we need to some discussion or.
Thank you, Dr. Aceng, for your nice presentation. There are two presentations from Dr. Aceng. Maybe right now we have 5 questions on the Q&A box. First, from Muhammad Yudin, he asked about, is there an effect of the use of adhesive dentures on the health of the mucosa? Because maybe it's used for a long time.
So, okay, thank you very much. Good question from Dr. Yudin. So, actually, so far, there is no report about the effect of using the adhesive for a long time, because if we use the denture adhesive as guiding from the manufacturer, so I think it's not doesn't have a negative result for the mucose, because after we use the denture adhesive, the manufacturer suggest to make a cleaning to our oral mucosa. So the remaining denture adhesive is not remain. So for me, I don't have any literature that denture adhesive may cause damage to the mucosa. Thank you very much.
Okay, maybe this adhesive or polydent is very good to maintain the dental performance.
Yeah.
Maybe the other dentist you can use it for your patient comfort.
So actually, for the dentist, if we make a good denture and fit well to the mucosa, so maybe we can minimize to use the denture adhesive. But in such case, when we need to use the denture adhesive, so maybe this option can be used.
Oh yeah, that's very helpful to us. The second question is from Dr. Andres. He asks, how about the TMD treatment? We can how we know that was successful treatment for TMD treatment?
Okay, so thank you, Dr. Jojo. This is my best friend, my classmate in residency. So the question is, when we notice that the TMD treatment was successful. Okay, so there's Azan. Can we stop it for a while? Okay. Okay, maybe we can continue.
Dr. Aceh,
Yeah.
may I say interrupting?
Yeah, please.
For Dr. Abul too, if you have, if you look the question in Q&A box, please choose 5 the best question of them, because there are 5 merchandise or giveaway from our sponsor today. Okay, thank you.
How many souvenirs, Dr. Isra? 5?
Yes.
Okay, maybe Dr. Abul choose 3 and I choose 2.
Yes, thank you.
It depends on the percentage.
Okay, or I choose 1, Dr. Abul, for it's already okay. So okay. Okay, we continue to the question, Doctor.
Yes, of course.
Okay, yeah. Okay, the question from Dr. Jojo, from Dr. Andres. Okay, Dr. Jojo asked about when we know that TMD treatment was successful. So, okay, so before we move to the treatment, so the patient come with the symptom and sign and symptoms. So they have a complaint. For example, they have a clicking, they have a pain, they have a limitation in mouth opening. So that's a sign, that's a complaint. So when we know that the treatment is successful is when the complaint is relieved. For example, the subject doesn't have any sound joint anymore. The subject doesn't. The subject could open mouth wider, and then yeah, just like that. So is the symptom and the sign is gone away. So we make sure that our treatment is successful. So that's my point, I think, for Dr. Andres. So that's why at the first when we do at the first time when we do treatment to the patient, especially in the anamnesis, so we need to make sure so what the patient complain, and then what caused the patient come to the dentist to get treatment. I think that's all for Dr. Andres.
Okay, thank you, Dr. Aching. And the third one from Dr. Ance,
yes,
she asked about how to resolve the pain caused from bruxism in all patients, even they have prosthesis.
Yeah, very good question, Dr. Ance, Bunda Dr. Ance. So
yeah, that's one of.
Yeah, Dr. Ance will have a souvenir. Yeah. Yeah, thank you very much. Very good question. So, how can we resolve the pain caused from bruxism in the whole patients? Okay, so as I mentioned before, that the bruxism is multifactorial factor. So, because there are many factors that can make a bruxism. So we need to define what kind of the etiology is. I mean, for example, in all patient M.Si already has prosthesis. So, in my opinion, because this is the all patient and already has prosthesis, might be the patient use a denture during sleep, because maybe Bunda Anja mentioned about the sleep bruxism. So when the subject use denture while she or he sleeping, so there is a movement. So the denture may be moving in the mouth, so it can make a laceration or maybe make irritation to the mucous. So at the first, we need to instruct or advise to the patient to not to use the prosthesis while sleeping. So because he mentioned about the old patient and has a prosthesis, but if the patient if the etiology is not coming from the prosthesis, so we need to examine what kind of the factor, what kind of the etiology, what kind of another etiology. So I think we need to examine the etiology, because as I mentioned, the bruxism etiology may have many type of etiology. So we need to like a predisposition factor, we need to find. Okay, I hope my answer here can understand by Dr. Anja.
Thank you, Dr. Asing.
Yeah.
The next question is from Dr. Syakrani Syahrir. He asked about, can we use the muscle relaxant for bruxism because they have a muscle contraction, or there's any treatment for this bruxism?
Okay, thank you very much, Dr. Saka. I'm sorry, I'm speaking bahasa. Dr. Sakriani asked about the muscle contraction due to bruxism. So actually, muscle contraction is one option to rehabilitate of the muscle fatigue. Yeah, in some journal they use muscle relaxant, something like diazepam, and then I'm sorry, I forgot the name of the muscle relaxant. But in my opinion, muscle relaxant is not suitable for the bruxism. Why? Because the muscle relaxant is a systemic effect. Have a systemic effect. If the patient drink the muscle relaxant, not only the muscle involved in the bruxism will relax, but another muscle can have effect. So we have experience with a patient come to our clinic. The patient consume muscle relaxant because they has pain, and after use or drink the muscle relaxant, he cannot awake, just sleep in the bed, because all the muscles affected by the muscle relaxant. Because I said that the muscle relaxant for the system is a systemic use. It can affect all the muscle. So for me, I never use a muscle relaxant for the patient. is there any treatment to repair the muscle? So yes, of course. Regarding to the muscle fatigue, muscle fatigue. Let's wait for a while. Yeah, I'm a little bit sweat. Okay. Is there any treatment? Yes, of course. In prosthodontic department, we use a splint to orthopedic splint to make muscle relax. So we have a orthopedic splint, and another treatment is to make the muscle more relaxed is massage. So we like to make a massage to the muscle using hot massage is preferable. Hot massage is good for the muscle fatigue. I think that's my answer for Dr. Shaka.
Dr. Abul, excuse me, because the time is up for the session.
Okay. Thank you. Maybe
we still have okay.
But please choose 5 questionnaires from the Q&A below.
Please, Dr. Abul. Yeah.
For the first merchandise for Dr. Indria Kirana, Dr. Aisha.
Yes.
Yes. Okay. Thank you. For the second.
For the second, maybe for the long explain, maybe Dr. Shaka, it's good.
Yeah.
Yes. Okay. The third. Because we have a closing ceremony, Doc. Sorry.
Me again?
Yes,
yeah,
please. Third, 4, 5 merchandise. It's going to.
From the time they ask the questions, maybe Dr. Muhammad Yudin, okay?
Okay. Congratulations, Dr. Yudin.
Please, Dr. Aching.
2 more, Doc.
Yes, Dr. Aching, you can choose it for me. It's a mute.
Okay. How many souvenirs left need to distribute?
2.
2.
Yeah.
Dr. Aching and me.
Yes.
Huh?
One from Dr. Aching and one from Dr. Abul.
No, the present Dr. Aching and me.
No.
No, I'm kidding.
Yeah. Just joking. Yeah. Okay. Okay. The number 4 is Rahmat Ritanga. Okay.
Okay.
I apologize because we have a limited time, so I couldn't answer your question. Yeah.
Okay. The last.
We still have one.
Yeah, the last one.
The last one.
Okay, I think Arya also. So actually, I would like to explain, but we have no time about biofeedback therapy. Arya Prasetya Bemaputra.
Okay.
Okay.
Thank you, Dr. Aching.
Yes.
Dr. Abul, please please
Thank you very
stay
much.
for delivering the certificates for Dr. Aching. The certificate, yeah. Please,
Thank
Dr.
you,
Abul.
Dr. Aching, for your nice presentation. This is a certificate of achievement for Dr. Aching Habibi Muda, Ph.D. Sp.Pros, as a speaker of main lecture in 4th International Conference on Biophysical Technology in Dentistry, held by Dentistry Faculty and Hasanuddin University. Thank you, Dr. Aching.
Yeah, thank you very much, Dr. Abul. So I can use this for my BKD next semester. Yeah, thank you. Yeah, thank you very much. I'm not worried again about my BKD. Yeah.
Please,
Okay.
Dr. Isra.
Yeah, thank you, Dr. Abul, Dr. Aching. The next is a closing ceremony, and there is Dr. Yossi gonna be lead it. Dr. Yossi, please, the floor is yours.
Thank you very much, Dr. Israyani, for leading the session 8 and session 9 for this virtual conference. Now we come to the end of our whole virtual conference of the 4th ICO-BTD, the 4th International Conference in Biophysical and Technology in Dentistry that held by Faculty of Dentistry at Hasanuddin University. And as a part of the closing ceremony, there will be a remark that will be delivered by the chairperson of the organizing committee to Dr. Gigi Dwi Putri. Please, the time is yours.
Testing. Is that clear enough, Dr. Yossi? Hello?
Yes, I can see you. I can hear you clear, Doctor.
Okay, thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Well, thank you for the time, Dr. Yossi. And thank you for the last presenter, Dr. Aching, and the last chairperson, Dr. Abul, and the last master ceremony before Dr. Yossi, Dr. Israyani. Thank you very much. Well, it's time for me to give some speech about closing. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. The Honorable Dean of the Faculty of Dentistry, Hasanuddin University, the Honorable, all of the speakers, the chairperson, and the participant of this virtual conference. All praise to Allah for His guidance and blessing that we successfully completed our virtual conference that had been held for the last 3 days. And this conference is attended virtually by 40 speakers for short lecture and 17 speakers for main lecture from 8 countries. And in this opportunity, I would like to send my highest gratitude to all of the organizing committee for their hard work and commitment in planning, preparing, and organizing the first virtual international conference held by our faculty. Aside that, I would like to thank to all of the Master of Ceremony, to the chairpersons and the speakers during this event for taking their time during their busy schedule to actively participate in this event. And thank you very much to the Dean of the Faculty of Dentistry, Hasanuddin University, who have given the honor to the committee to carry out and hold this virtual conference. Okay, thank you. I think that's all, Dr. Yossi. Thank you very much for your attending. Stay safe.
Thank you very much, Dr. Putri. And for all the participants, I would like to inform you that this is an annual conference, the ICO-BTD, that held by the Faculty of Dentistry, Hasanuddin University. So as this is the first time that we held this conference in virtual way due to the pandemic situation that happened in our country, but we do hope our next ICO-BTD, the 5th ICO-BTD, could be held in a very normal way, the face-to-face, a direct seminar. So hopefully our next event will be more, we could have more participants and more speakers from a variety or from different part of the world. So we could have a discussion with more fruitful, of course. And we're actually waiting for the Dean of Dentistry Faculty as an university to join us, to giving a closing statement for this virtual conference. And once again, it is an honor for us to have lots of international speakers came from Japan, from Taiwan, from Malay, from Yamen, and also from Indonesia. And we have lots of short lecture participants. 42 presentation have been uploaded to our YouTube channel in Dentistry Hasanuddin University, and all of the participants, all of the audience could access freely to our YouTube channel in Dentistry Faculty in Dentistry Hasanuddin University to see the whole of the virtual conference that been held from the first day, 2 days ago, till now, until today as the end of our session. And once again, we'd like to give a huge gratitude to all of our speakers, the main speakers, the short lecture speakers, and also all the participants and distinguished audience that giving very supportive, very positive attention and cooperation during our virtual conference.
Dr. Yossi?
Yes, Doctor?
While waiting the Dean, maybe I would like to inform some information about the publication to all of the participants, especially the participant in short lecture. If you want your manuscript to be submitted in the international journal, you can send us the full paper before 30 September 30, 2020, and you can contact our committee. Thank you.
Thank you very much, Dr. Putri. Again, the certificate will be given to all of the participants that has passed the post-test, and we have a passing grade of the post-test 70% of all. So we do hope that all of the participants could finish the post-test. The link post-test has been sending to all of the email, respectfully, to all of the email of the participant, and please answer or please done the post-test before 12 p.m. tonight. Jadi kami mohon kepada para partisipan untuk dapat mengisi post-test, di mana post-test ini merupakan persyaratan untuk mendapatkan sertifikat, dan passing grade dari post-test ini adalah 70%. Dan link post-test akan kami bagikan melalui email ke masing-masing peserta, dan bisa dikerjakan hingga batas waktu jam 12 malam nanti. Jam 12 malam nanti. Okay, thank you very much. Welcome, Dr. Ruslan.
Thank you, Dr. Yossi.
Yes, we would like to ask for your to give a closing statement according to our the end of our 4th International Conference on Biophysical and Technology in Dentistry. Please, Dr. Gili Muhammad Ruslan, M.Kes Ph.D, Spesialis Bedah Mulut Konsultan, the tag is yours.
Thank you very much, Dr. Yossi. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, all speakers and also all participants. We have reached the end of the 4th ICO-BTD, International Conference Biotechnology and Dentistry, and it's my task to provide some closing remarks. I would like to give a high appreciation to all of main speakers who has kindly shared their knowledge and experience in this conference. This is the first time we do a virtual conference, international conference. Such a privilege and honor to be ensured that all of you are able to become part of this virtual conference. It's my great pleasure that we had fruitful discussions, so I think 3 days is not enough. I would also give my deep respect to all of the short lectures participants for your positive participation. I observe all the excellent presentations and active discussion. Therefore, I conclude that the purpose of this virtual conference has been completely accomplished. Finally, on behalf of the Faculty of Dentistry, Hasanuddin University, I would like to express my appreciation to all participants for taking time out of your busy duties to attend this event. Also, I would like to give appreciation to all committee for this event to make a successful this event. I would like to close my remarks and officially announce the end of the 4th ICOBTD, a virtual conference. We look forward to see you again on the next ICOBTD event, wishing you all the future health, success, and prosperity. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Doctor, for officially end our virtual conference for today. Once again, on behalf of all the organizing committee, I would like to thank you to all of the participants, all of our main speakers, our short lecture participants, all of participants, all the audience for huge support and also participation during our last 3-day virtual conference. Hopefully we could see you again in our next ICOBTD event. Wassalamualaikum warahmatullahi wabarakatuh. Good afternoon, selamat sore, sampai berjumpa.
Assalamualaikum.
Congratulations to all organizing committee.
Thank you very much, Doctor.
Sensodyne Repair and Protect is a daily toothpaste for the treatment and prevention of dentine hypersensitivity. Sensodyne Repair and Protect contains Novamin, an advanced calcium and phosphate bioglass technology. A single Novamin particle ranges from about 5 to 20 micrometers in size. New Sensodyne Repair and Protect also contains sodium fluoride. The unique formulation has been developed so that both the Novamin particles and sodium fluoride are protected in their active form and available when brushed with in the mouth. When Novamin comes into contact with saliva, it releases calcium and phosphate ions to build a hydroxyapatite-like layer over and within the dentine tubules. This begins with an ionic exchange between sodium in the Novamin and hydrogen ions from the saliva. This ionic exchange causes a small localized rise in pH that promotes formation of hydroxyapatite. Novamin particles can bind to collagen fibers in dentine. Once deposited, these particles continue to react and act as a calcium and phosphate reservoir to build a hydroxyapatite-like layer over dentine and within the dentine tubules that also incorporates fluoride. This hydroxyapatite-like layer is chemically and structurally similar to biological apatite, forming the inorganic portion of dentine. The reparative layer formed by Sensodyne Repair and Protect starts to form after the first brushing and promotes the dynamic mineralization of dentine to build a substantive reparative layer over the dentine and within the tubules, which in turn reduces dentine permeability. Decreased permeability can relieve dentine hypersensitivity by decreasing the fluid flow within tubules, thereby reducing the activity of nerve endings. Sensodyne Repair and Protect delivers clinically proven relief from the pain of dentine hypersensitivity with twice daily Repair and Protect.